Sure, in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. So any questions, thoughts, comments can be sent by Zoom chat to the meeting host, co-host. And if you have a supporting resource link to share with meeting participants regarding an agenda item currently being discussed, share that link with the meeting host or co-host, and they can share it with meeting attendees. And all materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. We have our housekeeping out of the way. Good morning. Lovely to see fellow board members. We have a good-sized agenda today, but let's kick it off with roll call and acknowledge who's here. Tara, I'm going to turn it over to you.
Great. Kirsten, can you hear me okay?
I hear you just fine. Thank you.
Great. Okay, I'll start with roll call. I'll announce first, so we have two excused absences. One is Brenda Johnson and the other is Melina Moran. So I will not be calling their names. Okay, Kristen Isaacson.
Present.
Tony German.
Morning, present.
Bill Kramer.
Present.
Dr. Hemmings.
Present.
Carly Hood-Ronick.
Good morning, present.
Peter Starkey.
Present.
Great. Thank you, everyone. We have 6 of 8 members present for quorum.
Thank you. And we'll start today's meeting as we do all of our meetings, reading the health equity definition, and I'd like to invite Carly to read it this month.
Yeah, thank you, Kirsten. Good morning again. So our state health equity definition reads as such. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address 1, the equitable distribution or redistribution of resources and power, and 2, recognizing, reconciling, and rectifying historical and contemporary injustices.
Thank you. I did want to take this is a tradition that Brenda started in her role as chair that I really appreciate, and is a regular feature of our meetings. But I did want to take a moment in today's meeting to just reiterate that the Oregon Health Policy Board remains steadfast in its commitment to health equity. And this has to be the work of many, many people. And so we want to hold ourselves as board members to the same standards that we ask of our committees and of the agency, and that we hold this definition and the critical effort that it calls for us to do really at the center of our work. We think about our priorities framework, that kind of wheel image that we've spent a lot of time on. Health equity has been and will remain at its center and the primary focus of the Oregon Health Policy Board. And that work happens as its own focus in the center specifically. And it's also embedded into our kind of outer ring priority areas as well. And so as part of that center work, today we will review and discuss the draft letter of support in regard to the community action request that the Health Equity Committee, the Oregon Health Policy Board, at our April 2nd meeting. And to make sure that this work continues with involvement from this board and from its committees, that letter has been drafted to include try to focus on roles and collaborative opportunities directly connected to the Oregon Health Policy Board and its committees. So we'll discuss that in today's meeting as agenda item number 3. Thank you so much for reading that this month, Carly. All right, so speaking of the agenda, let's walk through what is on it today, and then we have a few business items. So top of the agenda, welcome our business items. Then we will hear the Oregon Health Authority updates. We will talk again. Agenda item number 3 is our board priority work area, health equity, followed by public comment. And then update about CCO procurement from the governor's office. And then the Oregon 1115 Medicaid waiver, general update, housing services planning update. And then the Oregon Health Plan bridge and redeterminations, which has really crossed an exciting threshold this month. And then we will have a bittersweet thank you and farewell to Trilby. And adjourn the meeting. So that's what's on the docket today. And I saw a link come through in the chat with the agenda, which has links to all the attachments if people want to follow along, not on a shared screen. So speaking of our priority framework, last month in the agenda, I do want to say that we were expecting, and for board members who were following earlier in the month, that we're not going to hear an update about OHA's strategic plan today, because it wasn't released yesterday. So it's hard for us to discuss it today. But I have heard that it will be released later this week, and we'll make sure to share that out to everyone. And I know that I'm looking forward to reviewing it as well. And so we're not talking about OHA's strategic plan today, but we will have that at our next meeting in August. And just for the record, we do expect health equity to be in the Oregon Health Authority strategic plan. And we'll really want to discuss how the agency's plan coordinates with both the direct and embedded equity work that's in the Oregon Health Policy Board work areas. But that will happen next month rather than this month. And yeah, that's our one change to the agenda, in case people were curious about that. So our first item of business this morning is to vote on the draft June 4th, 2024 Oregon Health Policy Board meeting minutes. The draft meeting minutes are provided as attachment number 1 in today's meeting packet. Is there a motion to approve the draft meeting minutes?
So moved. This is Peter.
Thank you, Peter.
Second, this is Tony.
Thank you for the second, Tony. All those in favor of approving the June 4th board minutes, please say aye.
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 Any opposed or abstained? All right. Meeting minutes are approved. Thank you. And so just while we're here in our business section, I want to take a moment to reflect on last month's meeting, which was pretty unique. I personally feel pretty passionate about this board's work around affordability, and my excitement in part is really rooted in the fact that that's not just I see, that I read and see that income is one of the most influential social determinants of health, and income is really unfairly distributed and suppressed. So I kind of think of our affordability work as like a short-term, long-term approach, as like how are we addressing these inequities immediately, while we work on some of the long-term changes that are needed as well to really break down barriers that allow everyone to achieve their optimal health. And I see curbing skyrocketing healthcare prices as part of that. So last month's conversation was really interesting as we dedicated that meeting to combine with the cost growth targets annual hearing and brought all these kind of voices of healthcare actors into one space, talking through different ideas of action around cost of care. And I know there's been subsequent conversations and reactions to all that. And that we've heard a lot of I know each one of us has heard countless stories about the impact affordability has on patients, not just stories, but experiences, on patients and the delivery system. And so as we think about access to services and what's available where and to whom in our state and how we take action on that. But I did want to invite, particularly with some of the committees doing this work, to kind of reflect on last month and talk about the board's work going forward as we come out of that hearing and into next steps around this work. Bill, Tony, you want to share your thoughts about last month and the months to come?
Sure. Thanks, Kirsten. I really appreciate your raising this to remind the board and the folks listening about the importance of the affordability issue and the crisis that Oregonians, consumers, patients, and purchasers are facing. I thought that the June session was very good, but in some ways it only scratched the surface of the problem and potential solutions. And I think there's a lot of work to be done, both to keep this at the top of the agenda for the board's work. This is one of the priorities identified by the governor for the work of the board, but also for the folks who are listening, the general public, that this is such an important issue. I think a lot of people feel in some ways helpless to deal with this problem. And hopefully the board can be a forum to not only talk about the problem, but some potential solutions. I thought the last month's session on the cost growth target program was really helpful, really very informative. But we also, as we discussed, that's only one lever that can be used. There are other levers that can be used, particularly recognizing that one of the drivers of high costs is what's happening in the healthcare industry and growing consolidation over the years. So I think that's an issue that we would want to take up in the future. I know Tony has some thoughts about this too, so I'll end my comments and pass it on to Tony.
Well, thank you, Kirsten, and thanks, Bill. Yeah, looking at last session, really incredible, informative work that was taking place, and really appreciate our colleagues around the state to come in and give some perspective and some good quality information of what they're experiencing on the ground. We had a multidisciplinary panel, those that are in levels of C-suite, those that are doing research. And so I found it really instructive for us as a board to pay attention. You know, I think we start these meetings focused on equity, and I think this is central to the question a lot of people are facing. And so I think our due diligence is to continue as a board to provide quality of information. And I'm interested in hearing more on this topic because it does matter for my patients. And so for them to get the care they need every day as costs go up. And so our attentiveness in the constructs that we've put in place for the cost growth target, for the healthcare market oversight, is instrumental in the tools that we've chosen as a state to move us forward, to pay attention to how do we create inroads to more affordability for individuals and make sure that that is equitable. You know, the issue of consolidation continues to grow, and we know that spending is a direct result of some of that consolidation. And so, you know, we had some conversations of, you know, as a physician, how my decision making takes place is one, from prior training, but ongoing research and ongoing attention to what do we need to be thinking about? What are those subject matter experts that can help inform us better? with regard to the research that is taking place with consolidation and some of the levers that policymakers are doing across multiple states and a focus. And there's some really positive things that are taking place in a couple different states as far as in California, Massachusetts, with cost growth containment. And so, we've had some conversations in our upcoming meetings. I think it would be really helpful for the public. I think it'd be really helpful for us as board members to have some more subject matter experts that are doing some of this research in different contexts of these domains of consolidation, and how we can continue to support the work that's taking place at the cost growth target and at HICMO. I think it was really interesting to hear some of our colleagues at PEB just talk about the challenges and the lack of transparency that we're seeing in certain sectors of the healthcare. And the market forces are moving in a direction which we really need to pay attention to. So I think that this, again, drawing this back to why we do this work is that so that a patient and a community member or a client can get the care they need when they need it.
True. Thank you for sharing your reflections and for your leadership in helping to identify next steps. So, Bill and Tony came to one of the board leadership meetings and we talked through some ideas. And so coming out of that, at our September meeting, we're going to invite some of these subject matter. We have invited some of these subject matter experts, and they have RSVP'd, yes. So we're looking good for our September meeting to really dive into hearing what some other states are doing and diving into a little more about the challenges around horizontal consolidation in particular. So Trilby, I see your hand up. We'll go to you next. And I would also like to open it up in case any other board members have reflections from last month or steps going forward on this area in particular. Trilby. Can't hear
There we
you.
go. I think I got it. Thank you, Kirsten. And I want to just underscore my excitement about the board inviting experts in. And I know that OHA staff is playing an active role in setting these things up. And I think that's going to be a wonderful meeting. Where we'll learn. The point I want to make was actually backing up to a comment that you made before we got to this subject. So I'm going to hold that for a moment just to see if there's other board members who want to continue with this conversation.
Anybody else on last month's meeting or topics for September? Carly, go ahead.
Yeah, I was on vacation last month, so wasn't able to join, but really appreciate Bill and Tony sharing kind of reflections on how the meeting went and both of your perspectives on the importance of keeping this really front and center for the board as well as the public. This is a new space, and we're all learning kind of what consolidation means, what practices around trying to keep healthcare costs contained and affordable for folks. And so I think learning from other states is a great idea, and will continue to encourage my peers and community-based entities to listen in and pay attention when we have the opportunity. The only thing I would add, and again, having not been in the conversation, I don't know how much this came up, but I think there is an opportunity for us to consider just access in general and the challenges around that. Affordability is certainly one piece of that. I know we're going to hear about the waiver and these increasing needs to address social factors within the clinical setting, and what that means for access to patients, what that's consuming of clinical care team time. So, there's a lot of sort of confluence happening at once, and I'll be eager to really dig into that and kind of think through how the board can be supportive in really making sure access, whether it's financial or time with a care team member, is pivotal to our work.
Yeah, I really agree with that. And I think we should echo that in our invitations to our speakers, that confluence is welcome and very appropriate. So when we think about consolidation, it's not just its impact on affordability. So yes, I'll be sure to note that. Thank you, Carly. Right. Trilby, take us back.
Okay, and actually, I mean, what Carly just said is a really nice tie-in, because what I want to comment on is the strategic plan. And as you may remember, the first goal is access to affordable healthcare. And so I think that really you'll see that reflected. What I did want to share is that it won't be released this week. It's more toward the end of the month and maybe even into early August. Part of what's going to be important for the agency is to take some time after receiving the governor's comments, which is what's beginning to happen now, and also to do the translations and really work on publishing the strategic plan in a meaningful way that is accessible broadly. So it's just going to be a bit longer.
Okay, thank you. That is a good, important update. And happy to hear that the launch of it is being thoughtfully considered. Okay, sorry, my mind's starting to whir on our August meeting now. I'll try to pause that. Okay, we'll when it comes out, we will look forward to receiving it when that happens, and then we will discuss it at some future meeting as appropriate. Okay. Anything else on last month before we have about 5 minutes before our next update. So there's time for more reflections about last month. I'd love to give some voice to a comment that I think I heard in that meeting and after, and I think will remain a challenge and an essential portion of this area of work, which is patient voice. And so I think there was some like indirect patient voice, especially in the opening of the hearing. But I think that is something that I would love us to continue investing in and prioritizing. Go ahead, Bill.
I didn't want to interrupt. I just wanted to second what you were saying, Kirsten. I think one of the things that we need to keep in front of us is how is the affordability crisis affecting patients and consumers? And we need to hear directly from them. It's not about statistics. X percent of people have medical debt over X amount, or Y percent of people are avoiding or postponing care because they can't afford it. That speaks to some people, but statistics really the story, and the story has to come from individuals. And I really hope we can provide a forum for individuals who are affected by high costs to speak up. One other comment is I'll make, this bubbled up at the last meeting, and I think it's going to be a continuing issue, is this is a hard problem. Affordability is very important, obviously, for patients, consumers, and purchasers, but finding ways to improve affordability, i.e. reducing costs, is a real challenge for hospitals, physician groups, the health plans. And I don't want to underestimate the challenge of that. And I would hope that we can find ways, particularly among leading hospitals and physician groups and health plans, to craft a way forward. There's a danger that this can slip into an adversarial kind of situation, and this is Oregon. We shouldn't do that. There are good people throughout among all stakeholders, and I think we do share the same goals. Finding a way to get there is hard, but hopefully we can find some common ground both in the goals and then craft a way forward. And that's the spirit in which certainly I, and I think other members of the Health Policy Board, will try to approach this. There may be some hard conversations and hard discussions, hard news, hard information that's put out there, but it's not meant in an adversarial or finger pointing way. We're all part of the system. In some ways, we're all part of the problem. We need to be part of the solution as well. So I'm sure we'll be encountering this challenge as we go forward. I hope we all go into it with the right intentions and with the right spirit.
Well said, Bill. Let's carry your words forward with us, and we might need to revisit those periodically too. But I sincerely appreciate that sentiment, and it's spot on. Thank you. Okay, well, let's take a moment before we dive into each of the agenda areas today Tara, would you mind pulling up our framework so we can just reground ourselves in our priority area focus work? As we move through our updates, we can hold our prioritization and our overall goals center. I don't know who's doing slides. Oh, here we go. Thank you, Suzanne. Okay, so this is our priority framework. Again, health equity in the center as the primary priority, and we will be hearing community letters as agenda item number 3, which will be good. And so as we hear our updates from the agency, both from the director and from on the TCO procurement and all sorts of, sorry, I'm trying to keep an eye on the chat at the same time and I can't multitask apparently. But as we move through our updates in this meeting, just the health equity is at the center, and then as we think about these affordability, behavioral health, CCO procurement, and metrics being our next level of priorities, how do the updates that we hear today fit into those and our future actions? So thank you for sharing that. And I definitely, I think Brenda was the original creator of this. Appreciate having the visual. Okay, and with that, I think we will move to inviting our OHA director, Dr. Sejal Hathi, to join us and provide agency updates. Like I said, we originally planned to hear an update on OHA's strategic plan, but that plan is still under review by the governor. And then coordinating review. So we hope to have Sejal speak to the details of OHA's strategic plan at our August meeting if possible, but maybe that's gonna cut it close again, but we'll stay flexible. But it will be shared with members when it's released, and we will have an overview of that at a future Oregon Health Policy Board meeting. So with that, I would love to invite Sejal to take the floor. Good morning.
And good morning to all of you. Good to be back. Again, hope you enjoyed a lovely 4th of July with your families and your friends. My husband and I, for the first time, visited Ashland for the Oregon Shakespeare Festival, which we understand is a cultural institution, if you will, of the state, and really enjoyed exploring that part of the state, and that too with a very passionate community, very passionate about the arts. It was wonderful. So I want to speak for a moment about my commitment to achieving our goal to eliminate health inequities by 2030 and to building a culture of equity and anti-racism at OHA. I am fully committed to working with you, OHA staff, and our partners to eliminate health inequities in Oregon. Our leadership team, our staff, as you just heard, have developed a concrete strategic plan, which we look forward to sharing with you upon our ability to release it. We believe by end of month or early next month. And to achieve this plan and advance our goal to eliminate health inequities by 2030, the staff across the agency, but especially in our equity and inclusion division, are critical. They have expertise in E&I in the discipline of diversity, equity, and inclusion that we know can accelerate the work of the rest of the agency and accelerate progress on our strategic goal. And they will accordingly play an indispensable role in implementing that plan and in strengthening our capacity to achieve equitable health outcomes in every Oregon community. And at the same time, the E&I, the Equity and Inclusion Division, can't do this work alone. Every division must be equipped, resourced, and supported to take greater responsibility and leadership in ensuring that equity is woven into all elements of our work. For us to achieve our 2030 goal, health equity must be practiced in every corner of the agency in the work of all employees, regardless of their roles. For us to eliminate health inequities, each of us at OHA must weave equity into every policy, every protocol, and every process that we shape. And the only way we'll get there, I believe, is through a whole agency and whole systems approach. The entire agency bridging silos and working together, building new relationships and strengthening partnerships. It will also take relentless commitment to measurement, to service excellence, and to accountability for delivering real progress for the people of Oregon. Oregon is the first state, as we all know, in the nation to set a goal to eliminate health inequities. It's a goal that we know we can accomplish because we've already shown that it's possible to reduce and even eliminate disparities. We've seen the profound impact of these investments in recent years, focusing our efforts on supporting community partners and trusted messengers during the COVID-19 pandemic was a strategy that eliminated vaccine inequities for communities of color and that saved lives. And we continue to invest in inequity. Last week's announcement of the Basic Health Plan OHP Bridge, a benefit that will eliminate cost barriers for a population that historically has gone uninsured, has equity at its core. Our strategic plan, too, is built on this foundation of equity, and each of the principal goals of it will hold us accountable to keeping equity front and center in our work. Personally, I'm committed to action to increasing specifically staff and manager support to do this work on behalf of the people of Oregon, as well as to accountability across the agency and with our partners to ensure we are moving forward and working together to accelerate progress on OHA's strategic goal. I'm more than happy to talk with any of you more about this if you have additional questions, ideas, reflections, feedback. So as always, don't hesitate to reach out. Happy to take any questions here too.
Board members, any questions for Sejal? As the representative of the agency, any topic? Go ahead, Bill.
Teja, I appreciate your comments and the focus on equity, which of course we all share. A number of board members in their earlier comments talked about the linkages between access, equity, and affordability. Could you just say a little bit more about your thinking about how those are linked? Because I think in many of our minds, they are linked. But we appreciate your thoughts about both conceptually and practically how they're linked and how we can move forward on all three of those together.
Yeah, thanks for the question, Bill. So I actually view access as a three-pronged stool, if you will. The first is the availability or convenience of care. The second is the affordability of care, and I subsume coverage-related conversations and policies like OHP Bridge under that, though affordability doesn't stop with coverage, as we all know. And the third prong or leg of the stool, rather, is workforce. And so making sure that we have a sufficiently robust, culturally and linguistically responsive deliver care to those in need when they need it. And of course, running through this whole conversation is equity, because access itself is often most compromised or least available to those communities that have been harmed by contemporary and historical forms of injustice. And so our very first pillar of the strategic plan is on ensuring that 100% of Oregonians, of the people of Oregon, have access to affordable care. Access is at the core of that strategic plan, and that's because access itself is all about health equity. And so there are, again, a number of actions in that strategic plan that I look forward to discussing with you in the coming few weeks that outline how we're thinking about expanding access to care and building a more robust workforce over the coming 3 to 6 years. And I think the board's ideas there, the work of the Health Equity Committee, the work of the Workforce Committee will be critical to that effort. So I look forward to engaging in dialogue with all of you here farther down the road to determine what policies we might put forward and support.
Great, thank you.
Tony, go ahead.
Good morning. Thanks for being here, Sajal. Really appreciate that overview. With regard to you raised the issue of workforce being a significant component. One interest I have and a concern I have is the time frame with which you have to train individuals in certain sectors of healthcare, and that training takes a significant amount of time. And with our goal being 2030, that time frame is approaching very quickly, and to augment our strategies and bringing in a workforce. I think it's premature for me to jump ahead because we're waiting to see the strategic plan. But I just wonder if you could comment on the thoughts on how we're going to navigate the challenges of there is a burden of time that it takes for a specialist, right? Or in primary care, whether that's a physician assistant, an NP, or an MD or DO, all the way down. Some of the training programs are going to be on the order of a year or two, but for a psychologist, that takes a good amount of time. So I'm just curious, not to get too much in the weeds, but an overview of your thought process. How do we tackle that?
Yeah, thanks for the question, Tony. I will say many pipeline development solutions or interventions have a much longer timeline than I think any of us would like. They're necessary, but they take longer to bear fruit. And so I think it's therefore all the more important that we think about not just building the pipeline from scratch, but also upskilling the workers that we have. So for instance, CNAs that may be interested in being nurses, right? Like, how can we leverage the existing workforce, which is largely also in many of those roles, disproportionately women and also people of color. How do we upskill them so that they can continue to progress across those rungs? And at the same time, how do we retain the people that we have? How do we invest in safety and job quality, in reimbursement rates, so that in reducing administrative burnout, so that we are not losing these folks to other professions, so that we are retaining them as full-time, so folks are not retiring perhaps as early as they otherwise would. We have a lot of providers, but I don't know that we are harnessing their full potential or their full time because the jobs themselves are not as they once were. And the patient population has become a lot more acute. And that combination is difficult. I think, dismaying for many. And so we have to think about not just recruitment, but also retention and amplification and making the jobs themselves, the settings of patient care themselves, more palatable.
Yeah, thank you so much. I can't highlight enough the attention to retention and where healthcare has gone and the burdens and the compare on so many different levels in different sectors of healthcare. And I think in the strategic plan, if it is still in the works, I think that thinking through what are those burdens that are driving people to lower their FTE, to transition to part-time work, to just leave the field. And I have seen so many colleagues in so many different sectors in mental health, in behavioral health, in RN positions across the board. And so we have put medicine is continuing to have new therapeutics, new interventions, new research, and so that comes with the territory. But I think there are certain areas where we make it far too complex for individuals to continue to do the volume of work. And so as we move towards a team-based care approach, I see there's such a value in that. And expanding, I think, Sejal, your comment to the effect that we need to elevate people in certain roles. Well, there are certain roles we can continue to create and think through that. I think community health workers, thinking of, where we don't have to train somebody for 8 years, but we can augment their skills just within a year or two to help the team-based care.
Yeah.
And so, yeah, really appreciate that work.
Thank you, Tony.
Carly.
Yeah, I would just add, and I think I was alluding to this slightly in my comments earlier about access challenges, just utilizing existing workforces that are out there. I mean, community-based organizations have lots of CHWs that could be deployed in new and innovative ways to support health more holistically and remove that burden that Tony's referencing from clinical care teams today. They don't even need 2 years of training. They're trained up and ready to go. So I think just looking at kind of role clarity around what needs to occur within a clinical setting versus in partnership with other entities is I hope something to see in the strategic plan, and aligns really well with kind of goals and priorities around things like the waiver, for example. So
Yeah, I completely agree, Carly, and the budget development process is yet young, but one of our intended proposals is to expand the ability of CHWs and doulas to serve Medicaid patients and make it easier for them to get paid by Medicaid and to navigate that system, which we've heard consistently from partners and traditional health workers on the ground can be otherwise very esoteric and complicated. So absolutely agree that we need to invest in again, building the pipeline of those workers, but also supporting those existing workers and navigating the systems in place. Well, thank you, all of you. If there are no further questions, really looking forward to next month's discussion with all fingers crossed. Our strategic plan will be out and we'll be able to have a in-depth conversation. If there are specific questions or areas that you want to delve into, please let us know in advance of August and we can prepare accordingly. And otherwise, my door is always open, especially around these ideas of workforce and access and things that we can do as an agency or should consider doing or supporting in the next legislative session. Would love to hear from you, and just thanks for your interest and your time.
Thank you for your time, Sejal. Appreciate it. And we do look forward to diving into the strategic plan once it's out. And I do want to add, I mean, I really appreciate the comments from fellow board members, especially around retention. So we're not just throwing more at a, at a system that spits them out quickly. So very much appreciate that. And I also want to add, Sejal, appreciation that, you know, when we adopted I remember when the board adopted the health equity definition, and then later there was a declaration of a public health emergency, racism being a public health emergency. And I remember board comments at the time kind of reflecting on like, what does it mean to have this 2030 goal? Like, it's great, all this sounds good, but what does that mean? And so I very much appreciate kind of breaking that down into, you know, measurable progress and benchmarks to make sure that like we are striving towards it. We are holding ourselves accountable to meeting it in a very in a real way, not just in a emotional or hopeful way. And so really looking forward to that and appreciate that focus. And then just before you go, I'd love to ask, like, is there any, you know, we've been a little focused on the strategic plan, but you know, those ideas are percolating. Anything that the agency is gearing up for the session, or other big updates on the agency outside of the strategic plan that you want to highlight for us?
So we were thrilled to announce that CMS had approved, you know, our foray into providing Medicaid benefits for the carceral population to facilitate reentry and ensure that there is continuity of care, of physical and behavioral health care for this population that has disproportionately faced access challenges. So that was an exciting announcement we made last week. We also announced, of course, the launch of the OHP Bridge program, permanent Medicaid expansion for American Indian and Alaska Native communities, 138 to 200% of the federal poverty level, and then also our basic health plan for that same population more broadly. And we've been doing a lot of work across the state over these past several days of the heat wave, just to ensure that individuals who need air conditioners or other support can stay safe and healthy during these 95, 99 plus degree days. I would say beyond that, you know, there are some conversations that are kicking into gear, as I'm sure many of you know, around the provider tax. We're starting to think more intentionally about CCO procurement. I know that we're preparing for a discussion here with Christina Narayan in the coming couple months. So a lot of things happening, but continuing to build the team, and I'm excited to make a couple hiring announcements in the next few weeks. But you know, otherwise, I'll just also note, I'm thinking aloud, apologies for that, but we concluded the regional visits, as you all know, and we will be putting out a mini report just sharing what we heard, what we learned, and some of the actions that we're taking in response to that feedback and that input. So that too, we will be sharing in August. And finally, we're doing a lot of work around cultivating the organizational capabilities that we need as an agency to be more accountable, to be more transparent, and to foster belonging. In other words, to be trustworthy. And I'm excited to share some of those actions and unveil that initiative again at the end of this summer.
Excellent. Thank you. Thank you so much. And Tara, when that, oh, okay. Tony, 1 second. Tara, when that community report, the community tour report comes out, that would be great to share with the board, especially in advance of our out of area of our own community meeting, so that we too are reflecting not making people repeat themselves and holding dear that being trustworthy. So we should all review that and keep that in mind. Tony, go ahead.
You took the words out of my mouth. That's exactly what I was hoping to learn from. I know it was a great body of work, tremendous work by OHA to do that coordination, and for all those tours. Thank you, Sejal, for doing that. I know that was really a number of organizations, mine included, really appreciated your visit, appreciate the interest and the active listening. So I just would like to learn from that from across the state, and I think this board would value that.
Awesome. Looking forward to sharing more and to discussing it.
Thank you so much.
Thank you.
Right. Okay, so that concludes our agency update. We'll move to agenda item number 3, which is discussing our priority work area, health equity. We have an action item here. So health equity is the North Star for our board's 2024 to 25 priority work. And this means all work is built on this equity-centered, anti-racist, anti-oppressive, culturally appropriate, and empathetic approach. At our May meeting, we agreed to accompany letter of support from the Health Policy Board to the 2 community action requests that were presented by the Health Equity Committee. And those letters focused on affirming transgender care and supporting recommendations from the Oregon Health Authority's Ombuds program in its 2022 end year report. So since our May Health Policy Board meeting, the Health Equity Committee liaisons, Dr. Hemmings and Carly Hood-Rodnick, have worked with agency staff to draft a letter of support included in today's meeting packet. This is attachment number 2. So today we'd like to take the time for Dr. Hemmings and Carly to kind of review and discuss the letter with our full board members. And our goal today is to finalize this letter with any needed edits from the Health Policy Board members before we share this letter with the accompanied Health Equity Committee letters to OHA leadership. So Dr. Hemmings, Carly, would you do us the honor of sharing the content of the draft letter with our fellow board members?
Dr. Hemmings, do you want to start? Do you want me to start? What's your preference?
You can go ahead.
Okay. So thanks, Kirsten, you teed that up really nicely. I don't have to provide a ton of context. Other than just jogging memories, we did look at the 2 letters that the Health Equity Committee had produced as a result of these reports and community input back in May. And Dr. Hemmings and I have been working with OHA staff and to draft the letter that's in front of you today. You know, I think at a high level in the letter, we really tried to reinforce the challenges and concerns raised by the Health Equity Committee, and specifically to highlight key areas that we as a board are committed to this work ourselves. And often that can be squishy to identify, you know, what is it specifically that we're going to do. But we did our best to come up with a few recommendations, and would really appreciate thoughts, ideas, questions about these commitments as we kind of seek a vote of support to finalize the letter and then submit it to OHA leadership, as Kirsten mentioned. So I'll just lift up, I think, in italics about 3/4 of the way down the page, there's a set of bullets around our commitments. And those, range from providing general support to really requesting more information from our subcommittees, Medicaid Advisory Committee, the Healthcare Workforce Committee, as well as OHA staff on available sexual orientation and gender identity data to really help us kind of stay on top of these issues. And then continue to collaborate with the HEC, of course, the Health Equity Committee, to host community-led conversations and try to identify challenges in this space. So I'm not going to read verbatim what the letter says, but those are kind of the high-level bullets around our commitment recommendations. Dr. Hemmings, would you add anything to that process or the content of the letter before we open it up?
No, I just, wanted to say that I think we forgot to add a statement regarding behavioral health. That's the only thing that I would add. I know we discussed it, but somehow we didn't include it in what our recommendations or acts is.
Great. Let's add it. What?
I guess I'm thinking where it says identify and support efforts to address gender affirming care inequities. Something similar verbiage, but specifically related to behavioral health. Because it is part of the ombudsman's report. And I know there's been a lot of discussions from the ombudsman's area recently. I think I went to a conference a couple weeks ago where this is, increasingly significantly an issue for us as a state. And I think it's important that we actually call it out.
Yeah, if I'm recalling correctly, and this doesn't mean we shouldn't include it, but I think the reason it hasn't yet been added was because we were playing with the notion of it being included more in the procurement and CCO conversation. But that doesn't mean it shouldn't be reflected in this letter too. So I think that's a great call out.
Okay, all right, okay. We'll be interested to hear the thoughts of the other members of the board and anyone else who wants to chime in.
Yeah, yes. Any other comments from other board members about, I think that the effort here is to both convey support and add specificity about what that support looks like, but then also use this to hold ourselves accountable to are we doing it? And so edits to this list, particularly the parts in the italics, are really welcomed. Go ahead, Tony.
Yeah, I can't say I have a ton to add. Just want to thank you for the work on this. I think the recognition and highlighting what the ombudsman's, as well as attention to gender affirming care, and us putting this in writing. I value this work and doing this. So I don't have any constructive additions or changes to the letter. Just really appreciate the effort.
I will add, Bill, I see you came off mute. I'm curious what your thoughts are. I'll add quickly for context. And sorry if I was choppy earlier. Tara's flagging my microphone might not be great, so I'm leaning in. We will be taking this back to the Health Equity Committee on Thursday for kind of final, yes, we're all in alignment. There are no major things missing. So at that point, I think we'll fold in these pieces of feedback and then I think bring it back to the board or at least board leadership for finalization. But Bill, what are you thinking?
I apologize for advance for what might be considered kind of like small, but the use of the term address, I'm thinking like the third bullet point, address Medicaid member engagement. I think I would hope we could maybe come up with a stronger word, and I think the intention is stronger. Address could mean just like talk about or do something, but if we could say something like strengthen or improve or engage, do more about more outreach or something like that, might be might just be a little more specific, and I think would indicate a stronger position as a board.
That's super helpful. Thank you. We can update that.
I do want to revisit Dr. Hemming's comment around do we want to more explicitly pull forward behavioral health in one of these? I mean, I know I had the comment, and I will hold it with me. I don't think it needs to appear in this letter, but just that I am reminding myself, especially as we go into these procurement conversations next, and in our future conversations, that the ombuds report really like called for increased care coordination, particularly care coordinate like behavioral health integrating better with primary care and stuff. And so I think like hearing that update from Sajal around the federal improvement of some of the incarceration coordination of care is great, right? That is a important progress along that measurement. And I think we need to keep looking as a board when we see other things come before us, how are we pushing forward this care coordination that was called out as a real challenge. I will be holding that center as we go forward in our work. And I do wonder if we want to see actually use the term behavioral health in one of our bullets here to really reinforce that focus. So we don't lose that thread, and we're reminded of that important work. Because I think the ombuds in that first bullet, when we say related to ombuds, like that ombuds letter is more than the ombuds program. I don't want to like it's like shorthand in a way that I'm worried that we're going to forget it in the future. So I wonder if we say like related to gender affirming care and ombuds call for increased focus on behavioral health or something like that, so that we draw forward what that is. I could imagine myself in a year, maybe I don't remember what that letter was, and I'm like, oh, ombuds program, it's very important, we need to support it, which is true. But the letter was really about the ombuds call to action around behavioral health.
I think that's a really good question for the Health Equity Committee too. We could pose that addition that you just suggested, Kristen, to the end of that first bullet on Thursday and see how that lands with the committee.
Yeah, I'll defer to you, Carly, and Dr. Hemmings about the right process for engaging the Health Equity Committee on this. But I'm certainly open and would be supportive of the group's preference to include something more explicitly about behavioral health care coordination in response and to follow up on the ombuds reports, recommendations in the ombuds report. I'll also say overall, I thought this was an outstanding letter and did a really nice job of articulating not only some of the issues, but our commitment to follow up on these issues.
Hey, I want to make sure that we give opportunity for all board members to speak here. Oh, Tara's putting it on the screen. Thank you. Peter, I think you're on the phone now. But if you just interrupt, come off mute. And any other comments?
I'll add one thing I guess I'm curious about from peer board members. You know, we tried to include, we have a slew of committees that are feeding up into the board, and that's a lot of work and staff time and you know, volunteer time. And so where possible, I think we tried to call out, you know, the committees helping guide recommendations that we could react to really align their work with the boards. And I wonder how that sits with people. I wonder if, you know, that feels like the right process, or if folks have other opinions on kind of pushing some of this work to really ask the committees to advise or put recommendations forward for us.
Really, go ahead.
Well, I just want to offer up that from an OHA perspective, engaging the committees feels like such an important step. You know, strengthening that liaison between where the board wants to be directing both the agency and itself, and really mobilizing the insights, the expertise, the ability of the committees to enlarge the board's ability to hear from community. All of those things seem so important. So activating them seems spot on from my perspective. And the other thing I wanted to underline about Dr. Hemming's comment is that in gender affirming care in particular, there's such a strong interface with behavioral health. When you think about some of the recommendations that were adopted by the agency after the legislature passed its bill in this area, there are assessments required in order to access some of the treatments that we want to make accessible in this state. And those, it's going to be very important to be sure that people have access and that care is coordinated across with behavioral health. So I'm eager to hear what the HEC will have to say about how specific to get there, but I think they're going to be very supportive of emphasizing behavioral health in these actions.
Thank you so much for saying that, because that's one of the reasons why I brought it up as it relates to the second to last bullet, because it's very much interconnected.
Great. So I think with a potential edit around underscoring behavioral health and changing the word in the third bullet, Tara, changing the word address to something stronger, like increase, amplify. I don't know. We'll let our liaisons and the HEC maybe find the right word there, but I think the sentiment is to convey a more powerful word, more action oriented and forward momentum word. I think those are the edits that I'm hearing, and then the next step, but the Health Equity Committee meets on the 11th, so in just later this week, they'll discuss this. We'll run this letter of support by their members, and they can discuss this draft letter, and then I would we can invite the HEC co-chairs and our liaisons. We meet regularly to kind of I think I would propose, assuming that the edits are along these veins, that we finalize and we send. And if the liaisons feel like the edits are more significant than that, then we bring it back to the board for review, or either in a meeting, or board leadership could individually kind of discuss, connect with board members individually to confirm support. So either route, maybe I would propose that we give some leeway to our liaisons, Carly and Dr. Hemmings, to make that determination. Does that sound okay with board members? Great. Okay, I do want to just call out and appreciate Carly and Dr. Hemmings' leadership as liaisons with the Health Equity Committee in working with staff to draft this letter and identify these next steps, and do this hard work of the liaison role of back and forth. Is this right track? How do we fine tuning these edits, and then holding the board accountable? And I think this was already said, but I think it's great that these action items and appropriate that these action items include the committees of the board, not only because health equity work needs to be done by many and it is not siloed, but also because there's just this wide, amazing, impressive portfolio of work that is done within our committees. And so, like, let's just be real about the incredible efforts that happen within the committees. And so really appreciate that. And then I think it's appropriate that it's reflected here. So thank you, Dr. Hemmings. Thank you, Carly. Dr. Hemmings, I see your hand up. Go for it.
Yes, I just wanted to clarify next steps. So as far as the HEC goes, HEC, we will share with them our discussions today. If they would like to add some additional changes, we would then bring that back to the board, or would Carly and myself make a decision as to whether or not to just accept, if it's not a significant change, to accept the changes that the HEC is requesting. Is that correct?
That is correct. I
Okay.
think you guys can use your judgment, and we can report out. Y'all should report out to the board, kind of where this lands, so that everybody is aware of the final letter, and its edits. But
Okay,
yes,
great. Thank you.
and thank you. So we should vote on this letter, though. I think not only to approve these changes, but also some symbolically to say, yeah, we, the Oregon Health Policy Board, are sending this letter. So I am seeking a Health Policy Board vote of approval on this draft letter of support.
This is Tony, motion to approve.
Second.
Thank you, Tony and Bill. All those in favor of approving this draft letter of support, say aye.
Aye.
Any opposed? Any abstentions? Great. Peter, we don't know how you voted. Sorry to put you on the spot. I think Peter had to switch to the phone, so Tara, I think unmuting yourself on the phone is different. Is it *6?
Yeah. Peter, you need to press *6 if you want to unmute, but I can also, this is Tara Chutok, I can connect with Peter to confirm his support. Confirm his vote on the letter.
Great. Okay. Well, again, thank you, Dr. Hemmings and Carly, for your leadership thus far and for your continued leadership on this letter and as our liaisons to the Health Equity Committee. Okay, let's take a 12-minute break. We'll reconvene at 10 o'clock and move into public comment. Okay, thank you all. right, everyone, it's 10 o'clock. When you're back, if you would kindly turn on, board members would kindly turn on their video or give a thumbs up, some signal that we are back and have reached quorum. Thank you so much. Next, we're going to move into public comment. This is in the chat, but if anybody would like to sign up for public comment, there are some instructions in the chat, and if you message the host or co-host, Tara will get you signed up. So before we get started, I will add our usual that the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not representation of the Oregon Health Policy Board or its members or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. And to help keep us on time, we'll start a 2-minute timer. Thanks for putting that up. For each commenter, we kindly ask that commenters conclude their presentation when the timer is complete. So please know that written and verbal public comments will be reviewed and discussed following each board meeting by the board chairs and staff to determine appropriate next steps. So we have 2 people right now signed up for public comment. I'd like to first invite Micah, you can correct me, Contreras to speak. Mika, are you there?
Yes, I'm here. Can you hear me?
Oh, I hear you excellently. Thank you. Go ahead.
Thank you so much. Well, good morning. My name is Mika Contreras, and I am the Executive Director of the Lynn Benton Lincoln Health Equity Alliance. And I'm here today, this morning, to speak about the sudden and unexpected firing of Leanne Johnson from her position as OHA's Equity and Inclusion Division Director. I want to start by first recognizing that Leanne is widely recognized, trusted, and respected at both the state and national levels for her unwavering dedication to equity work. And she has many accomplishments over the years as E&I director. And in fact, she had just received a national award and also a state award from a regional health equity coalition celebrating her efforts. We know that a press release was released by the agency that wrongly portrayed her firing as a voluntary departure, but we know this is false. She was terminated and her state access was revoked within hours. Her dismissal occurred without clear explanation or discussion, and this decision undermines trust and confidence in OHA's dedication to advancing equity and inclusion across the state. And I'm here today to ask for some transparency and accountability from OHA leadership, including Sejal Hathi, Dave Baden, Chris Kautz, Jennifer Midkiff, and Ashley Thurstrup, specifically in regards to the specific grounds for Leanne's termination. Without this, the lack of clear information regarding the reasons for her termination, coupled with the misinformation that came out in the press release, will lead people to believe that this termination was either due to a lack of support for equity work from OHA's leadership, or that the decision is a result of the nationwide backlash that we're seeing against equity efforts and advancing justice. All right.
Thank you, Mika. If there's additional words that or even your full statement, if you wanted to send that in, we certainly welcome it and we'll review it. Thank you for sharing today. Next, I'd like to invite Annie Valtiera Sanchez.
Thank you. Thank you for allowing me to speak. My name is Annie, but I am representing one of the regional health equity coalitions as well. There's 9 of us, as you might know, and we are grateful to work with so many partners in our regions and directly with community members. And this is, I second what Mika just shared. My comments are also around the transparency, the lack of transparency and accountability. And I know, like, listening to this meeting this morning or previous meetings, you often talk about, holding the board accountable and knowing that health equity is a top priority area for OHA. We want to bring this up and be able to ask for some transparency, as Mika shared, from the leadership in regards to specific reasons for Leon Johnson's dismissal, why the decision was executed so abruptly without transition time or input from the team. I mean, the division has grown from what it used to be an office of equity and inclusion to an equity and inclusion division, has grown largely. And why was the team not consulted in this transition, or even made aware prior to? And we also have concerns around any planned reorganization of the equity and inclusion division and its impacts that it may have on equity initiatives, including as regional health equity coalitions, as this is how we operate. And it just wants some answers and accountability and transparency moving forward on how this board provides transparency and processes as you guys make decisions and execute actions. Thank you.
Thank you, Annie, and thank you to both our commenters today. Are there any additional requests for public comment?
Yes, Vern Sabo here.
Welcome, Vern. Go ahead.
Yes, I wanted to alert the board to the need to prevent discrimination against healthcare providers as it relates to reimbursement, specifically CCOs. When Senate Bill 1509 passed in 2012, the legislative record is very clear that varying reimbursements can be based only on performance or quality measures and not on type of provider. The trouble has been enforcement. So moving forward, with any universal health plan or continuation of the Oregon Health plan as it is now, with the bridge coming forth with 100,000 more Oregonians, needs to be addressed. I served on the Health Evidence Review Commission for 10 years. 2016, we changed policy so Oregon Health Plan patients could get chiropractic care. I'm a chiropractic physician. That was 8 years ago. I'm still the only chiropractic physician in Albany that accepts Oregon Health Plan patients because of the low reimbursement, which is less than half of our normal fees. And so this would apply to all other covered health benefits within the CCOs, within the Oregon Health Plan, that are within our scope to provide. And if we're going to get more providers, that it really needs to be addressed. The 2 pain management clinics, Corvallis Pain Management, Blackstone, independent. One's an osteopathic physician, the other's a medical physician. They provide all the injections and so forth. And they no longer accept Oregon Health Plan patients. And so we need all hands on deck. So I'm hoping that the board will address or keep this in mind as we move forward. Thank you so much.
Thank you, Vern. And just before you go, Vern, for the record, just because how we do signups, would you mind restating your name and your affiliation if appropriate?
Yes, Dr. Vern Sabo, I'm a chiropractic physician from Albany. I represent the Oregon Chiropractic Association, and on the federal level, the American Chiropractic Association, but I am in practice as well.
Okay, thank you so much. Okay. Any other requests for public comment? Okay. Well, thank you for those who joined today. And as a reminder, we do accept written comment. And people are welcome to sign up. It's an important part of our monthly meetings. With that, next on our agenda is Coordinated Care Organizations Procurement Update. I just want to make sure, Tara, are we? Oh, yes, I see Christina. Excellent. Okay, so Christina Narayan, Senior Health Advisor to Governor Kotex, is joining us today to discuss the upcoming Coordinated Care Organization procurement and the Oregon Health Policy Board's involvement with community engagement. So thank you for being here, Christina. Please begin whenever you're ready.
Yeah, thank you. Good morning, everyone. We have at least one new face since the last time I joined the meeting on my screen. So welcome officially. My name is Christina. I use she, her, hers. I'm happy to join you all today. I think what I've been asked to do and what I'll endeavor to do in a brief 10 minutes, and no, there are no slides, is to explain the governor's office's latest thinking and the governor's approach to the procurement and how that's emerging into direction for the agency. To do so, you know me pretty well, you know that we'll just open up the hood and kind of look at the parts. And what I'd really like to do is to talk through some of the questions that we've been asking and how those pieces are starting to come together as we work through the scoping, which will continue through the fall. We'll also talk briefly about some emerging ideas for where the Health Policy Board can meaningfully contribute to the development of the procurement, especially into next year as this work really ramps up. And then I'm happy to take any questions to the extent that there's time. Trilby, I might ask you to help keep me on track, and I'll endeavor to keep my notes in front of me, but no promises. So I think what's really important to do is to just ground ourselves a little bit in the agency's 2030 goal to eliminate health inequities. As the governor wrote to the board back in January, that is a priority focus for her. It's a commitment that she supports. We in our office and the governor is looking at the procurement as a tool to align toward that goal. And so I think it's important to say that outright. There are also, I think, some real realities and environmental factors that are just difficult to ignore. The board is very familiar with these issues, and I think it's worth just repeating for the public and to really set the tone for how we're approaching the procurement. It dawns on us that many of the state's issues and challenges are similar to 1.0, right? We have a health and human services budget that continues to grow. We are continually challenged to define the value for members through that budget. Costs are rising, inefficiencies, they frustrate everyone. They frustrate members, they frustrate providers. They have tangible effects on education and public safety costs as well. And at the most person-centered level, access to quality services and care coordination is still a critical priority and a North Star for the CCO model. And we haven't achieved that North Star. We also know that, you know, your ability to access any of these services and truly experience the benefit of the Medicaid program 100% is affected by where you live, what community you're from, the language you speak, and many other factors. So here we are, third procurement, same issues. And we have stabilization and regrowth to do post-pandemic and a workforce crisis that is all too familiar to this board and something that is top of mind and that our office is very much aware of. So what do we do with this? What is the opportunity in the procurement to kind of realign, reset, and make progress towards some of these, I think, old but still relevant promises, but also how do we bring in new ideas and kind of align with the overall approach that this administration is taking around the governor's 3 key initiatives for housing, education, and behavioral health. You know, it's it's difficult to just not talk about the one process because of how relevant it still is. And I think there are a couple of things that are really critical to the original vision of the CCO model that the governor shares that we will be looking to extract through this procurement process. And that is very much local accountability for population health outcomes, budget accountability and transparency, and solving at the local and community level, aligning and leveraging our carrots and sticks to do that. And when we chat a little bit about the role for the Health Policy Board, I think it really harkens to that original vision of how do we know what we've done and is that working the way that we said it would work? The other kind of the other thing that we've been throwing around is, I think, the reality that the 2.0 process was very elaborate. It was a Herculean effort by this board. It was in a lot of ways co-developed in terms of the strategies and policy priorities that emerged. And we also have achieved many of the policy recommendations that the board put forward. Some have not been fully achieved and many have not been fully implemented. And so it begs the question of, with the 2.0 process that was arguably centered around health equity, do we need to reprioritize from that list, clarify what is within the role of the CCOs, and double down on those strategies for the next procurement? And how can we ensure that that work isn't just put on the shelf for the issues and the policy recommendations that we haven't fully achieved? I think what would also be helpful to level set is just the practicality of the tool of the procurement. I think there's a lot of mythicism around it. And ultimately, what the procurement is and how the governor is viewing the procurement is the state defines what we purchase. We set expectations for who is performing that service. And it's our obligation, especially with a contract of this size, to demonstrate the value for the public through that contract. And so I think the governor is taking a very pragmatic approach to delivering on some of those promises and doing an inventory of what we said we would do in 1.0 and 2.0. And then there's the elephant in the room. We have a lot of commitments that were in large part co-developed and born out of community engagement that don't align neatly with the contract cycles. That's the Healthier Oregon program. How do we ensure that we're extracting value for members in that program? The same way we would expect on Medicaid. We have the health-related social needs benefit, which is going to require a even more than 1.0 new level of community collaboration and convening power by the CCOs in order to coordinate that benefit to the fullest extent of its value. We also have the carceral settings waiver that we're very pleased to have our STCs approved for. Same thing at the local and regional level. How do we ensure that the next procurement and the participants in the next procurement truly have that level of community connection, convening credibility, and can deliver on what the state is now asking them to do and will 100% double down on in the next procurement? So I think with that landscape view, you know, that's the what do we have now? That is a pretty list of where have we been? What did we say we do? Are we doing it? And so I want to bookmark that with What that has resulted in with the agency and the agency's leadership is really a request from our office to just understand where we are. How do we know that we've been making progress on some of those 1.0 and 2.0 recommendations and efforts? Is what we know a readily accepted measure by the people who participate in the program? How can that evaluative process help identify and prioritize where we need to double down and raise the bar? And the bar will be raised for the next procurement. The expectation's a decade into this experiment. It's no longer an experiment. This is our delivery system. We believe in the model. Expectations will need to increase for the next procurement. So how can that evaluative process help us identify what's working now and double down, but also, I think, acknowledge that there are some key core delivery needs that can probably be improved and set that expectation through the procurement, but also give, I think, this CCOs and providers in the community an opportunity to understand what success looks like, so that there isn't a gotcha. Our goal is to have clear expectations, be able to translate what a successful application looks like, and spend time with all partners to understand how we meet that, because ultimately that's in service to the members. So I think the second end of this is, what does the governor want out of the procurement relative to her statewide initiatives? We have an opportunity with the new administration to say, yes, we're going to deliver on these promises and we're going to prioritize what we need to kind of ramp up. And also, we have 3 key initiative areas in housing, education, including early learning, as well as behavioral health. And how can the procurement as a tool, Medicaid as a program, a statewide program, set statewide objectives relevant to her larger system goals for the state? And I think that issue that I want to emphasize is role clarity for Medicaid. I don't think it's appropriate, and I don't think you'll see this governor say that Medicaid is the tail that wags the entire state's dog. It does have a very particular role, and I think it's incumbent upon the state, with all of our partners and the board, to understand where Medicaid can support overall statewide initiatives. To do that, we're chatting internally across our teams and doing some of that work. On the housing side, some of that evaluative process is already occurring in understanding our major contracts through the Oregon Health Authority and how, for example, housing elements are captured. That work, I think, will be more clear here in the fall, again, in our scoping phase, and would be happy to return back to the board in October or at the board retreat to share more about how those statewide priorities are emerging. Ultimately, I think what success looks like for the governor is, again, being able to articulate how we're raising that bar on the promises that we said we would do and how we're going to make sure that we're meeting them. Identifying those galvanizing key issue areas for this administration relevant to her larger administration goals, so that everyone knows where they're rowing for the duration of the contract period, and so that the state as well can align. And I think this is where the Health Policy Board comes in when you think about your subcommittees and kind of some of the programmatic elements relative to the agency's administration, how we can align those systems in service toward those larger statewide initiative goals. Ultimately, I think what success looks like at the end of this procurement is, or rather at the start of the procurement, right? That's the first benchmark. What are we buying? Is a clear understanding of what those expectations are, a clear understanding of how to meet those expectations in the procurement process, a clear demonstration of what we expect the value to be for members and the community out after this demonstration period. And we have to be able to articulate how all of those things align in service to the 2030 goal to eliminate health inequities. We think that by the board retreat, we should have a understanding and a firmer scope of how this translates into an actual project plan. I think it's very important to the governor to have a collaborative conversation with the CCOs and Whether that's some of the existing tables or needs to be a new table, I think that's a question, but that has been our general approach with our stakeholders. And I think for folks who are probably listening, they can expect that as well. Finally, I think what you all are probably waiting for is what is the role of the Health Policy Board for community engagement in this process and for the broader work after we're done scoping. I think, you know, I had the opportunity to chat with the governor a little bit a couple of weeks back, and I just want to reaffirm that she views the Health Policy Board as a significant resource for a public pulse because of all the subcommittees and the expertise that lives on this board and throughout the work of the board. I think there is an incredible validating role that the board can provide throughout this process. And no way will there be an elaborate process like 2.0. I just want to say that outright. I think when you think about our ongoing commitments, which were co-developed and had significant community engagement, when you think about the 2.0 process that we haven't fully implemented and need to dial down on, that also included just incredible community engagement. And what we really want to leverage the board for is to help us understand some of those qualitative experiences to help shape expectations for the procurement that we can't capture from our data sets. And so I started by talking about the 1.0 process. We chatted a little bit, or I guess I talked at you about our ongoing commitments for the HRSN waiver, as well as the carceral setting benefit. We take that very seriously, and it's very difficult to understand community sentiment about the availability and just accessibility of a CCO if you're a system partner or a non-traditional system partner like an educational institution or a housing authority. In order to set those expectations, but also in order for us to determine who a successful candidate will be or an application will be, the credibility in the process to really deliver on this benefit, we're going to need help articulating what that looks like, which starts with understanding what we have and how things are perceived and how we know. So that is the first concrete area that we've identified as a real deficit for us in terms of our visibility that the board can play a significant role in informing and shaping. I'm sure there will be more as we get through the scoping process through the fall, and can definitely return to the board in October, but that's where we are as of now. I will stop there. I think that was a full 10 minutes of me talking with no slides. And so I'll let Trilby tell me to have slides later so I can hide my face, but we'll stop there and see what questions you have. Hopefully that level of transparency was helpful and less confusing.
Oh, thank you for joining us, Christina, and for sharing reflections from Governor Kotek. Board members, any questions, comments, reflections? Tony, go ahead.
Great. Thanks for being here, Christina. I really appreciate your comments and feedback and giving us some grounding from your conversation with Governor Kotek. I wanted to draw back, and I'm sure this will be the work in progress, but do you have some early ideas for us as a board of what are those expectations that you refer to that we want to see from a CCO?
Yeah, I'll give you a sense of, thanks, Tony. I'll give you a sense of what we're beginning to look at. And I think this is something that agency leadership will need to take to the CCOs as well, around what are those key measures of how we know we're doing. You know, one place to look is at the 16 key deliverables that the state has for CCOs. We can also, you know, we can pick any issue that is a pervasive complaint, take access, for example. We can look at some of the metrics we have on, I would argue they're not the best standards, but time and distance standards, and really understand how out of network services are working. If there's a floor that should be established, if a certain CCO is truly lagging behind the others and why? Is that a regional issue, or is that an issue within a CCO's control? What does it mean to have a basic expectation for access for certain services in the next procurement? I think there's a volume of places to look. Understanding what collectively the data we have tells us, and using that data to prioritize those key areas that have really lingered, that are core to the delivery of a health benefit, is kind of where the governor's priority focus is. It's not super sexy, but it's basics. It's the basics of the service that you expect for health insurance. And it's the basics you would expect for the differentiating factors that make CCOs so unique and not standard insurers. And so it's access, it's care coordination, it's any measure of our metrics. I will say, I think that there's a role here too, and I can say this from the governor's perspective, and I don't know that you can say it from the OHA perspective, but expectations are great. How you incentivize and also enforce those expectations is a necessary conversation that's part of the procurement process.
Thank you. I would love to do, if Christina, you don't mind, a bit of a repeat back to kind of check for understanding of the overall picture and the board's direction. So I heard you talking about kind of this general landscape assessment of that the governor's office is undertaking with the agency, of knowing where we are and assessing kind of where to double down or where to raise the bar. And that effort is underway, and maybe there'll be some ability to discuss more of that in the fall. Is that timeline?
Yeah, we're currently scoping and asking these questions. It's always scary to say the questions you're asking aloud and not have full answers for them, but here we are. We are using, I think, this time to scope out and ask these questions. What do we need to know in alignment with the governor's current direction through the fall? I think, me personally, I am viewing the board's retreat as a real anchor point for getting to a concrete place for the board to be able to just go. I think from this initial scoping process, we've identified this question of understanding the community's assessment of the CCO's role as a convener, perceptions of governance, accessibility to community stakeholders as a key 1.0 promise, right? And also a necessity for our commitments through this next procurement that are already in motion. And so that's one, I think, very tangible and big question that the board can help us answer.
Okay, great. And I also want to repeat, almost so for my own, repeating for myself and for the board, although a lot of us weren't here in the 2.0 process, but that was very intense for the board. I wish Brenda was here to speak to it a little bit, but
it was a lot of work.
It was a lot of work, a lot of travel around the state, very intensive listening sessions. That was great. And we're going to make sure we carry forward the lessons we learned from that, but we're not going to redo that. To the extent that the board is engaging community, I heard a request to help understand qualitative experiences that data does not show. And so thinking about our community meetings, we have one in November, and then have thought we will have many more in next year. So focusing on the qualitative experience, pulling forward qualitative experiences that data doesn't show, and then speaking to this availability and accessibility of the CCO system, and kind of adding some of these experiences about what it looks like from I don't know, I think I wrote non-traditional, but I think you mentioned like school settings, like other participants in communities that are interacting with our CCO systems, but aren't necessarily CCOs themselves. And of course, open to edits, and we're not finalizing what the board's plan is around community engagement at this meeting, but I wanted to make sure that I'm hearing the right direction there about what the current thought is.
I think that's right, and we'll definitely be able to, in support of the board's work, provide a little more specific direction as we get through more of this scoping phase. I think ultimately, you know, what would be helpful to understand and why that's relevant to the procurement is an indicator of that the CCO's ability to really deliver on where we're asking them to stretch. This is hard work. And I think every CCO has been showing up at the waiver tables, ready to do the work. And it's only going to get more difficult to merge these systems. And what we need to understand is the commitment and the readiness to do that work, and really demonstrate that there's the buy-in to do it for the long haul. I mean, whatever the contract period is, it's a very big commitment the state is making in service to these programs that we're just getting off the ground.
Yeah, and that speaks to the mismatch that you referenced at the top about like our goals are operating on this level and our contracts are actually, they're not aligned timelines per se. Tony, go ahead.
Yeah, I wondered if in the conversations, governor's office has perspective. As we're seeing, we had a conversation earlier today on consolidation of care and larger entities and larger players in the field. And one thing I think when I look back at the foundation of CCOs and the interest, and I look at comments from those that founded it, is that these being local entities. And I worry a bit about the cautionary tale that we're seeing across the country of larger players in the market. And I just wonder if there has been a conversation about attention to that. And as we look at contracts of this nature, is there thought that perhaps we should be paying attention to the integrity of those local control and those market players?
Thanks for the question, Tony. I think two things from the governor's perspective. I think one, it's important to understand that the governor is tracking some of the consolidation that's been happening over recent years, in particular in the Eugene area. So we're very much aware of community sentiment, I think the realities for patients and providers, and are working closely with the health authority to understand those impacts as those transactions occur and move forward. I think your question specifically about whether or not, and I'll translate your question to, will the procurement make a choice about the type of entities that provide this service to Oregonians in the state? I think I would answer by saying, where the state is going for the delivery of this benefit and what makes the CCO model unique in our upstream focus on metrics soon, right, with the 966 study and some other work, where we are going with our outstanding commitments that have been community driven and have told us that we want to focus on the social determinants of health and health related social needs, and these connections to our system partners at the local level. Understanding that work now and defining that level of community connection will be core to a successful implementation of the Medicaid program. And I think we're still looking at the procurement as to how the levers of the procurement can sustain the delivery of that benefit at that local level. So I don't have a response to the actual who can apply question, which I kind of infer from your question. But I will say where the values of this program are driving, and I think the governor's commitment to this trajectory tells a very important picture that should be seen pretty directly.
Appreciate that. Thank you.
Go ahead, Bill.
Thanks, Christina, for your what you shared. Could you just remind us very briefly, and I apologize if I missed this earlier or if there's a written document already in circulation, roughly what the time frame is for the procurement process? What's happening this fall with winter? What are the deadlines? When will this heat up? When is it likely the board would be engaged in some way? When is the community outreach? I don't need the detailed stuff, or you just want to refer me to something that's already been printed, that's fine, but I think it would just be helpful for all of us to get a sense of the overall time frame.
Yeah, Bill, we can definitely, thanks for the question. We can definitely circle back in writing with a sketch for the board members. I did a poor job of looking at my notes this whole time, so I won't endeavor to give you specifics. I will tell you what my internal governor's office timeline is for scoping and shaping some of the direction to the agency, and that's through the fall. The levers for the actual project management structure for the procurement, because even if we just flip the book and reinstitute things today as they are, it's still a significant undertaking and there's a lot of administrative process there. So that's underway. The policy development arc, just loosey-goosey, is you scope through fall, you start to refine key questions for policy development toward the end of the year and well into probably the first quarter and second quarter of the next year. There are certainly some simultaneous processes that are occurring there, but I think I would say with some level of confidence that the board's contribution to be integrated in a meaningful way would be through 2025. But we can get you some specifics from the actual project team, which is probably more helpful.
Good, thanks.
Yeah.
I think that's helpful to hear and in alignment with how we're kind of planning out the board's content for the board's meeting and the board's kind of traveling and doing more community-based meetings in 2025. So glad that those are on the same track.
Yeah, hopefully a breath of relief. I mean, I think I feel like it's necessary to say there are a lot of irons in the fire right now, and I think that's good. The agency is working incredibly hard across multiple initiatives, and it's stretching by and large part the same teams. And so I think I actually think that's in alignment, the reality that we're in right now with the governor's approach, which is to understand how all of these things are working together cohesively instead of treating each project as its own separate thing to accomplish. And so I hope what folks kind of take away from the open hood here is we're just trying to see how everything aligns. And within that alignment of what we need to deliver on, where else we can kind of stretch and set new North Stars for some of these key statewide issues that we know we want to tackle, at least from this administration's perspective.
Pausing for a second to see if any other board members have questions for Christina. Feel free to raise your hand or just interject. Go ahead, Tony.
Hard to be asking a lot of questions here. I just have many interests in this, and this may not be the right forum. And I think probably just, Trilby, you might help me with this. But I think, Christina, it's something to think about. I'd be curious, you mentioned this will be our third iteration, and what are we doing differently is a curiosity that I have with this. And we're doing many different great programs. Certainly, we've navigated through some remarkable changes. One of them that stands out to me is pharmaceuticals, and I just spoke about consolidation. But in this sector, I think greater market power as far as the state to navigate negotiations with medications. I know that this is a challenging topic because CCOs benefit and they support the structure and the construct of how the program's in place as far as reimbursement for those. But I do see that is a larger price tag for a number of insurers, and a curiosity of an investigation if we're looking about how can we create more affordable medications for our community members. And so when we have all these different silos, and I think the other elephant in the room is PBMs. And so we know that the state auditor took a look at this. There's no transparency. It's very opaque. And in these different settings of different multiple payers, it's quite concerning to me because when my patients go without insulin and they're going without their blood pressure meds, you know, it's onwards of 20–30% of patients find that medications are not affordable despite having this coverage. So we don't have the answer for it, but I think an investigation, a thoughtfulness to what are we doing differently as a state in this arena.
Yeah, thank you for sharing. Thank you for just sharing your provider experience as well. I mean, I think it's a good question. I think it's a good question for us to take back. I do think that there have been several explorations around this space as it relates to how the pharmaceutical benefit is managed. I'm not fully up to speed on where those landed, but I think you're right. It's a curious question to ask as part of this procurement when we look at some of the landscape issues that we have to manage for over the next X number of years. What I will mention, just for the sake of mentioning, I think, is that the governor, as speaker, was very supportive of the construction of the Prescription Drug Affordability Board and is very supportive of their prescription review work, drug review work, as well as looking forward to their recommendations on the UPL that they have been recently tasked with. We're a little disappointed to have a pause on the drug review process, but 100% support a reset for standardizing that process and making sure that the tough decisions the board makes have the full confidence so that we can take and build and grow off of those decisions. I think that there are a lot of efforts happening right now around prescription drugs, and I think this might also be a case, just from my vantage point in our office, of understanding how all of these lanes converge. I don't have a good sense of that now, but I think just, you know, thinking about OHA's program where DCBS is, I think the legislature has a role here. I don't know how those things fit.
Go ahead.
Thank you. It's a tough question. I appreciate your thoughts, Trilby, too.
Sure. And yeah, Tony, it is a tough question. There's a lot of history there. And as Christina alludes to, history with the legislature. What I wanted to share is that the Healthcare Cost Growth Target Program has taken a look at this because, of course, it factors in a very significant way to cost growth trends. And that might be a place to ask Sarah Bartleman to share a bit more about what that committee looked at in terms of efforts, recent efforts, and where they have landed us as an agency in trying to address this. And yeah, that's something that they looked at probably within the last 6 months. So that information is probably fairly current. I know there's still evolving efforts at a staff level to create a common table to really bring together all the subject matter experts on pharmacy and all the various efforts that are underway to make sure that we are, as Christina's saying, using all possible levers and clear on our shared goal of bringing down those costs in a number of different ways. So we could get information on that for the board. I think it'd be a really interesting thing to reflect on.
One thing I might add is just curiosity I have around Array RX for our state and that as a tool.
Yeah.
And how that might be an avenue to see where we might lower prescription drugs for people.
Yeah, and that got particular attention from the audit committee, that effort, and it is continuing to grow. More and more states coming into the fold there. So that would definitely be featured as part of what we'd want to tell you about.
Thank you, Trilby, for connecting that follow-up information with the board.
I'm gonna leave now before there are more questions.
Yeah.
From Tony.
Well,
Sorry, it's one of those mornings for me.
No, I appreciate it. I joined late, but I think this is Trilby's last meeting, so I just want to officially say thank you for her service. And hopefully she's off doing more fun things than we all will be doing this fall.
Thank you for that, Christina. My camera just chose this moment to flake out on me, but hopefully you can hear me. I really appreciate that. And I got to tell you, listening to all this makes me feel sad that I won't be here for all these conversations. This is such great stuff that y'all will be tackling. And I look forward to hearing about the successes and the challenges.
Sure, there will be both. Well, thank you for joining us today, Christina, and for all the work that you spoke to and are helping to lead. We'll look forward to reconnecting in the fall and hearing more of these details about this endeavor. And we'll stay in contact as the board develops, sets our community meetings for 2025 and to develop a plan and maybe list of questions that help elicit that kind of qualitative experience data that we're looking for, and making sure that plugs in.
Thank you. We'll see you in October.
Okay. All right. And with that, we'll move on to agenda item number 6, our 1115 Medicaid waiver, general update, housing services planning. I'd like to invite Steph Jerem, friendly face, to present next. Oh, there's Steph. Great. Welcome, Steph. Steph is
Trying to get my camera going too, so.
Yeah, your camera's like a funny gray thing right now, but yeah, Steph is the OHA's 1115 waiver policy director. Going to share some general updates and housing services planning information for Oregon's 1115 Medicaid waiver. So happy to have you here today, Steph. Take it away with or without a camera.
Okay, we're gonna see.
There you are.
Okay, we're gonna try that. Found the laptop computer, different angle. Sorry. Okay, hi everyone. Welcome. Steph Jerem, she/her pronouns. Happy to be here today. Sorry about cameras. I think Chilby and I must be an OHA thing going on right now with our cameras. Happy to be here, and I'm here to talk about the 1115 Medicaid waiver, and I'm hoping, Tara, you're going to be able to get slides going. Lovely. And I'll just start out by saying there's a lot of information on these slides today. My goal was to just have the information out there. I'm going to generally speak to it. If you have questions, feel free to pop in and ask them. Figured more was better, but we'll just make sure to try to keep on time as well. So it's been a little while since we've spoken, and just wanted to make sure that we have all the information available. So to go to the next slide, there are a number of things we're chatting about today. I'm going to do my brief overview that I always do just to orient anyone who might be watching. We'll be talking about the timeline for the health-related social needs, or HRSN services rollout, an update on climate, the ongoing launch plan for upcoming service additions, and then a quick update on the community capacity building funds. If you go to the next slide, please. I'm just going to do our brief overview. This is pretty standard, but just as a reminder, if you go to the next slide, the 1115 Medicaid waiver is focused on our Oregon Health Plan, our Medicaid program in the state. Every state has their own Medicaid plan, but it has to follow the federal government's standard set of rules. States can ask for permission to change or waive those rules for certain benefits or payments. And it's really an opportunity to test and implement new innovations using that Medicaid funding. So Oregon has done this many times. We're definitely like to utilize waivers to explore new options. And we renew every 5 years. And so this waiver that we're talking about today is the 2022 to 2027 time period. And if you go to the next slide, these are the major changes that we're implementing and that we'll be talking about today. The extended OHP eligibility for young children, youth, and adults. So that's continuous eligibility and enrollment for children from 0 to age 6. And then 2 years of continuous eligibility for everyone else. That's already in place. That's been rolling. It's great to see that. We've seen many states following in our footsteps. I think I've talked about this before, but CMS has been using our waiver as a template for these other states. And so it's really great to see that. We also have an opportunity to use health-related social needs supports. And so this is focused on a number of different areas, and then coverage for young adults. So on this slide, you'll see we're focused on health-related social needs, similar to what we talk about with social determinants of health, but this is really focused on the individual. And so thinking about the social and economic needs that support an individual's ability to maintain health and well-being. I think there are lots of examples to think about. We have some on this slide, but in our waiver, the focus that we have is on climate-related needs. So this is really mitigation of climate. Thank you, Tara. Housing, nutrition, and outreach and engagement. And so I will go in depth on all of these, but this is a great overview slide in case anybody needs to reference it. It really talks about our climate supports. Here are the devices that are available, housing supports, nutrition supports, medically tailored meals, outreach and engagement. I will go into these in more depth, but this is, again, a reference slide. And on the next slide, just as a reminder, HRSN service eligibility is still a smaller subpopulation of all OHP members. And so in order to be eligible for the services we'll talk about today, we need, you need to be an OHP member. You then need to be in one of our covered populations and then also meet the additional clinical and social need criteria, which is helpful to kind of orient us to who we're talking about. That's my
And
overview.
Steph, sorry, on that slide with the circles, are the size of those circles actually representative or is that illustrative?
Illustrative.
Thank you.
Okay, timeline for the rollout. Go to the next slide, please. This is something you've seen before. So climate services launched in, actually that should be March 1st of 2024. I will give a more in-depth update on how that's going next. The housing services launch will be in November. Again, that focus of our first population will be on those at risk of becoming houseless, preventing more people from entering that chronically houseless population. We will then have nutrition services launching in January of 2025. And then we have ongoing opportunities to continue to expand our waiver and to use more of our authorities. And we've, part of our conversations that we'll continue to have, and it would be great to talk to the board about, is to really think about how our system is prepared or not to continue to expand. So while we have all these great opportunities, we have to match it to the actual ability of our state to provide those services so that we're not in a situation where, you know, everybody has a high need and we can't actually provide it. I think that would be equally as frustrating and difficult. The next slide, and I know I'm kind of cruising through these, but I want to leave plenty of time. This is our focus for the summer, our timeline and key milestones. So we are focusing on really getting this is a little bit weedy, but this is to get you a sense of what's happening within OHA to prepare for these. We are working on amendments to our contracts with CCOs. These are annual amendments, and we're having to do a couple of different amendments to be able of the services. So we have a November 1st amendment, and then we have a January 1st amendment that we're working on. This is standard. We go back and forth with CCOs, give draft language, make sure that there's agreement and understanding of what that looks like. And so that's in purple here at the top. We are also doing that at the same time for nutrition, which will launch in January 1st. So that's happening on our contractual side. In yellow, we're working on our community capacity building funds. And so these are the funds I'll talk about later on in detail. This is happening this summer. We're getting them out. Recipients will be receiving notification of their awards, and then disbursement will begin. And then in August, we'll be finalizing a lot of language. There are also RACs, Rules Advisory Committees we've been handling, and really moving forward on our contractual language. If you go to the next slide, this is our high level for fall. And so you'll see that we're working on readiness review, making sure that our housing and our outreach and engagement, that our state and our CCOs and partners are ready for those services to go live. We're finalizing contracts. There's some go live dates, and then also that continued funding disbursement of our community capacity building funds. I recognize that these slides are maybe a little difficult to read, but the point is that there's a lot of work going on, a lot of different work streams that we are building through, and we have a lot of partners that are having to work with us on building out towards this big go live for housing in November. So with that, I'm going to move to our more content of the conversation. So if we go to the HRSN climate rollout slide, and then go to the next one. This launched in, oh, can you go back one, please? Thank you. So this launched in March of 2024. This includes these devices that we have here. Really has been important leading up to things like this heat wave that we're having right now. Air conditioners and air filtration devices for heat events and wildfire smoke. We also have mini fridges in case there are, thank you. For temperature controlled medications, portable heaters for winter, and then portable power supplies for home medical equipment. Really important when we're seeing electricity losses or potential for, proactive shutting off of electricity in high fire risk areas. We really want to make sure that people have access if they're needing home medical equipment, electricity. The next slide is our eligibility framework. This is to help show, again, I know there's so much content on this, but I welcome you to take these slides and kind of digest them. This is our way of understanding eligibility for devices. It's very similar to what it might look like for housing and nutrition. And so you see on the left first, they need to be part of one of these eligibility groups. If you remember, we've been trying to support people who are in transitionary time periods, moving across systems, risk of destabilization or vulnerability, where they're not getting continuity of care. We really want to come in with these wraparound supports. And so they have to be part of that eligible group. Then they have to have a clinical need for the specific FIMIC device. This isn't too much of a surprise from our federal partners, CMS here. They want to see this tied to medical supports, clinical supports. We tried to get around that a little bit by having our medical supports be really broad and by also having it be focused on a transition time period or event rather than a diagnosis. But you'll see that's how we've kind of built that out. And then they have to have a social need. And so the social need here is that they don't have a device already that's working, and they also have to be able to use the device safely in their primary residence. And so that's what we're working through with our climate devices so far. That is really our framework, again, those steps 1, 2, and 3 for all of our HRSN services. If we go to the next slide, we'll give a little bit of an update on how this has gone. So our team has done over 40 presentations and connections, just I think it was actually from January until April, in lots of different spaces, really wanting to make sure that folks throughout the state are aware of this program, aware of eligibility. We realize it can seem quite complicated, and so just getting familiarity, getting exposure to that. We have monthly provider technical assistance calls. We have bi-monthly partner work sessions. And so this is with any HRSN partner, housing, nutrition, climate. We have monthly webinars in both English and in Spanish. We have monthly work sessions, and we also have office hours for CCOs. And so all of those have been highly attended, have been really successful so far. Most of them are open to any partner who is interested in engaging in this work at any time. And if you go to the next slide, you're probably interested in devices we've actually gotten out. You can see here in the 3 months since launch, and this was up until July 1st. So we've seen nearly 1,000 devices delivered. Really exciting to see that. This is not a program that is able to be responsive in an emergency necessarily in these high heat events because of the amount of time it takes to be proactive in getting somebody their devices. You need to be able to have the request forms go out and have, confirmation and validation and all the different steps. And so this was never meant to be that way. All that being said, we have seen CCOs really stepping up in the last week. I have multiple examples of CCOs who have been working with the state. Our state ODHS partners have been really figuring out ways to get any devices we have on hand out to Oregon Health Plan members and others in need. So it's been really great to see that activation and just the willingness of partners to come together to get those out and really reduce any heat-related incidents. And if you go to the next slide, you'll see that the program has been ramping up as there's been familiarity and exposure. This is the monthly. So you can see that they've started to go out more and more as, CCOs are familiar, providers are familiar with access to the programs, members can self-refer in all these instances as well. And this is setting the foundation for what housing and nutrition needs to look like. So I know I'm talking a lot about climate, but it really is the same structure by which we're going to be able to do the rest of our waiver HRSN delivery. So I'll pause there. Any questions on climate?
Carly, go ahead.
Yeah, thanks, Steph. Really appreciate this context and the update on the state of the state with regard to climate. I have a couple of questions, just curious from an OHA perspective, how do you feel like this piece of the waiver has gone? Is this what you were expecting, I guess, at the outset? Does it feel like we're behind the ball as a state in terms of getting these supportive devices out the door? That's one question. And then the second, I guess, would be, and this may be a bigger question for the entire, all of the sort of domains within the waiver, but I know that supply is an issue. So if we're looking at the supply side of any of these needs, whether it's housing, air conditioners, food resources, demand supply issues are going to be real. And I wonder if we're bumping into that already. Last summer, for example, I know that our team at our CBO had a difficult time finding enough air conditioners based on demand, and the waiver hadn't even been live. So I wonder if we're running into those challenges, or kind of what the thinking is around supply side with this new benefit.
Thank you, Carly. Great questions. So to start with your, is this going as expected? I think generally, yes. We knew that this was going to be a little bit, I'd say easier of a lift, because we're talking about devices. You're not talking about, supporting someone in navigation into housing. So this is a great test for us. It really gave us the ramp up. It also honestly has helped us internally in knowing what it takes to get to these programs launching. And so it has really kind of preloaded us for housing to start thinking about things way sooner. There's been a lot of trust building and trust that's required to be able to do this in advance of contracts with CCOs and with providers. And so a lot of things happen simultaneously that in an ideal world would actually happen consecutively. Like you would do this and then the next step would build on it. And instead we have to do it all at the same time. So climate was a good test for us to do some of that work that I think we're going to model a lot on, and we have some lessons learned to improve on. The difference I would say is that we've also been able to use vendors, and this is a little bit wonky, but the vendors don't have to have the same requirements. So a vendor would be a Home Depot or an Amazon, where it's just getting delivered, a device is getting delivered. It's not the same additional layer of having an actual provider out there working with the individual. We have that in some cases, but the majority is really happening through vendors. And so we do have some kind of untested growth in our HRSN provider space. So that's certainly something that we'll be watching carefully and building towards in November, because I think that that'll be particularly important for the housing launch. We really can't do it without HRSN providers partnering with us. But overall, yes, I would say it's been really successful for us in this climate launch. And then in terms of supply and demand for the climate specific pieces, part of why we did this focus on preventive was because we could start ordering air conditioners in March and really start to see some of those, get 1,000 out the door before we're hitting heat waves. We also are relying on some partnerships within OHA and ODHS, where we have existing devices in some cases. This is happening right now in that we have a stockpile for a state climate program. And so we're just wanting to make sure right now that we are responding to what the needs are, and recognizing that it's maybe not how we want to see it in the future years, and that we'll use different sources differently, but that right now it's an emergency and we need to get devices out. So something that we're definitely tracking and aware of, and the advanced purchasing programs allows us to not impact the state supply in the same way, because it comes directly from from the actual manufacturer. Yes, Bill.
Thanks, Steph. This is a great presentation and really good information and a great program. Related, kind of building on Carly's question about the success of the program, to the extent you can measure it, to what degree do you feel like this program is able to meet the need? Are you meeting 50% of the need, people who would qualify for these programs and need these devices, or is it 25%? Where I assume there must have been some estimates at some point about what the need is. To what extent are we actually being able to meet the full need that's out there?
That's a great question. I would say, I mean, we do have estimates. It would be hard to match that. You know, we have ramp ups in our estimates. So I think we're generally on track with what we were expecting. I would wager a guess that one of the things that we're going to have our analysts start to dig into is looking at our actual denials right now. So individuals who are expressing a need were denied because they are not an HRSN provider or don't have the HRSN eligibility category. And again, CCOs have really been trying to work with our agency and to meet that need. There's other ways that they can flexibly use funds to meet that need for the individual. And so we start to understand, again, if you look at the grand scheme of this being a test, right? This is a innovative demonstration. Does this work? What are our gaps? And so those gaps are what we're certainly going to be looking at to understand who had a need, who isn't getting met by the waiver, and are they able to be met in another way, flexibly through CCOs, through a county program, through our state program. It's a lot easier with climate because you have, again, just like defined devices. I think that's going to get trickier when we start to look at housing. And we've already seen that in some cases, other states who have started this before us, who may have an individual who has a voucher in hand and can't find housing. And so you start to say, we have people who have need, they actually have the resource, and we don't have maybe the stock of housing. And so those will start to get pretty complicated for us to be able to say, how do we actually meet that person's need? And I, you know, look forward to wrestling through some of that with all of you as we start to launch this too.
Yeah, that's very helpful, Steph. And I understand that it will get more complicated in the subsequent programs. And also, it does make sense to look at denials to see if, you know, there might be some other ways of meeting the needs of those folks. But I'm also interested in those folks who do qualify. To what extent are we meeting their needs? Does that, if we're not, we're only meeting a small percentage, do we need to do greater outreach? What's the level of awareness about these programs, just so that even the people who do qualify are able to get the devices and ultimately the other services that they need. So just encourage I know you all are trying to do these things, but just encourage you to keep in front of yourselves and us. You know, what's the total need out there, and to what extent are we able to meet it? Is there something more we need to be doing to reach those folks? Thanks for your good work on this.
Thank you, Bill. Okay, we'll go to Tony next, and then I want to make sure that Steph has time to do the rest of her slides.
Yeah, sorry, Steph. Really tremendous work. Really excited about this work and what OHA is doing. I was curious of the learning and the coordination of care, if you will, among different organizations, is climate being the test, and then moving into these other sectors. I'm curious of, you know, it sounds, and correct me if I'm wrong, but a lot of it has been information sharing to CBOs and partners across the state. I was curious, you know, this last week I was shooting some emails back and forth with my local CCO and the work that they're doing in a proactive approach. And I was curious if you guys have learned what has been effective strategies. So, you know, this is my public health hat, is thinking of how do we do outreach directly to people to identify, and this goes a little bit to Bill's question, are we identifying the eligible people, or is it more people that are coming through into CBOs and that? We have a wealth of data in healthcare centers. You know, I think of a community health center as we have a quarter of OHP patients. And I'm just wondering, I know it's something I've been bringing up with my own community health center. You know, how do we run our data in Epic? I'm curious how Kaiser or Providence or Legacy is running their data to say, hey, this patient has CHF, they're recently houseless, you know, thinking through that. So I just wonder if there's some learning that we could expand upon to be more proactive in our approach rather than reactive.
Sorry, I have a kid home from camp with me, a little coworker.
I know that very well. So if you missed part of the question, that's like my household right now. So I got you.
Thank you. Yeah, schools are schools are closed today that don't have AC, so I got him home. So we are doing a couple of things. I think CCOs are absolutely doing some proactive work. This is, we know eligibility, and so being ready on day one to be like, who is likely to need these services has been really important. We've encouraged that with some of their climate eligibility as well, to say, who is at risk. And so wanting to make sure, especially with older adults who are one of those transition categories, to make sure that we are proactively doing outreach and engagement. That is actually our fourth HRSM service, is that outreach and engagement. And so we've launched some of that with climate. We will be launching more of that. I'm going to talk about that in a second. I know I'm running late on slides. And then we also in our agency have the ability to do some proactive assessment of who we think would be eligible. I've been trying to talk through whether or not, what does that get us? Is it helpful to know that? Or, we've heard from CCOs that there's likely already going to be, people have been calling daily as it is for housing. And so trying to figure that out as well.
Thank you for that. And thank you for the team help there. You're doing a good job in the background.
Yes. Okay. Let me, if we can, Kay, if you don't mind bringing the slides back up. We have a lot of slides and I'm not going to go through all of them, but I just, again, want to offer you some familiarity for what they look like. So to start, if we go to the next slide. We're going to talk about housing and those expanded outreach and engagement services. So the next slide just gives you the rundown of what the housing services are. Housing tenancy sustaining services, these will launch. So these are some navigation supports. These are also things that are, helping someone learn how to work with their landlord, or helping to be able to do some advanced planning for how to stay sustainably in a rental, or help with lots of things that will keep you in your housing. Some medically necessary home modifications and remediations. So these are things like ramps and grab bars, or pest control. Rent for up to 6 months, including past due amounts. This is pretty huge. We're the only state who has gotten a waiver that includes arrears, which is past due amounts, and then rent for up to 6 months. Many states don't have that. They just have one. We would have liked it to be 12 months, but 6 months is what CMS was willing. Utility setup and costs for up to 6 months. Also really important. We wish that this had been layered on with some of our climate needs because of the air conditioners and devices, but hopefully we'll be able to match them up. And then storage fees in particular situations. The next slide is, again, a little wonky, but this is the actual eligibility criteria focused on housing. And I'll say that we're continuing to work with the federal government on this. We've been really seeing a convergence of systems and definitions in these spaces, and that's challenging. And so we need an individual to be currently housed, show that they need some support maintaining that housing, flexibility in what housing can look like, which gives us an advantage of using this in a Medicaid space that we don't have in some of our OHCS spaces because of HUD requirements. This third bullet is particularly challenging for us as a state that we're working on with CMS to see what options are in this space, but because of definitions that are at a federal level, they also want us to have an income that is 30% or less than the area median income in the area. And so that means that just being Medicaid alone doesn't guarantee it. There's an additional income test that we're trying to work through how that will be operationalized. It's different across the state, pretty complicated. We're not thrilled about that. And then have a housing clinical risk factor. If you go to the next slide, this one is who we actually expect to see getting these services. And you'll notice it's a lot of like acute, let's solve the problem, let's keep someone from being stuck in a situation that will lead them towards homelessness. So first bullets, you know, an example, someone has a chronic illness, they lose their job and they need help paying rent while they're looking for work. Perfect situation where somebody needs a short-term support, 6 months would support that while they're looking for additional work. They're not going to end up losing housing or at risk during that time period. Potentially someone has a hospitalization or they have an injury and we need to help support that. We can identify those people in a hospital setting, understand that they're going to be at risk of losing their job or can't go to work during that time period. How do we keep them in their housing and not make that an issue? A family who's doubling up by moving in with friends or needs financial help to pay costs to stay in that housing really reduces the pressure in some of those situations where we can keep someone in a situation, recognizing it's not a long-term permanent solution, but again, that's what we're trying to do with the waiver. So here are a couple other examples. It's a great slide to think about when you're trying to say who's actually going to get served by the waiver in November. And if you go to the next slide, you'll see these are the expansion of our outreach and engagement services. And so again, this is another HRSN service paid for by the waiver, really helps with some of the navigation supports that we know have been maybe more challenging to fund in a sustainable way in our state. And so outreach and engagement providers will be identifying members, helping them understand the process to access the services. We really want to see these outreach providers be culturally specific, culturally responsive, linguistically accessible. They'll be able to then connect the members to the actual services to address those needs. And then help them understand what the whole array of services are to be able to say, I know you're coming in for housing. Do you also need nutrition support? Do you also need a climate device? What else are your needs in this space? If you go to the next slide, this is our outreach and engagement process. And so a nice slide here that basically shows what this back and forth looks like for housing and other HRSN services. We'll have these outreach and engagement providers. This could be a county. This could be a culturally specific organization. This could be a small healthcare location. Lots of examples of what these providers could be. They identify and engage with individuals for HRSN services. They're able to then access and document the eligibility and needs. And so they can help fill out any form, that form to the CCO. CCOs then authorize or deny the service. And in this space, they are likely looking at trying to get a sense of that clinical need and whether or not there's some type of clinical need that they can reference. They can say, oh, you know, they went to this provider here and they probably have this situation going on. Again, not requiring a diagnosis, but just demonstrating that there is a need. And then the CCO can then refer within their provider network. And they'll let, this is a closed loop referral, so they'll let that provider know that, yes, that person received or is getting a referral for these services. It goes back to the providers who can then help that individual in actually accessing the service. And then you see it bounce all the way down to number 6. We'll see that actual provision of services. And then the outreach and engagement providers will continue to support the member as needed. So those providers, you're seeing a type of social case management in this case of really trying to help someone navigate through our system and access the different providers, really trying to keep it as non-burdensome on the member as possible in navigating across these multiple systems. Our next slide, briefly, again, these are our milestones. We kind of talked through that. I'll just highlight that we have some public comment for our rules in September. And then we're also doing, you'll see down here, this engagement series, this roadshow. I would actually maybe call that roadshow more of information fairs. We're going to go out regionally and just make sure that providers feel comfortable and connected. We're going to do technical assistance on site. We're going to be able to help members who are interested in understanding more. It's really more about, making sure that everybody feels like they have the information they need for go live in November. The next slide, the next two slides actually discuss that a little bit more about our engagement and how we're going to be doing this. Similar to some of the questions we had, really trying to learn from climate. We had those 40 different services or 40 different engagement opportunities, and we're trying to do that a little bit more intentionally and in advance to say, here's a space you can all engage here rather than us going out to 40 different ones. We'll still do that, but like really wanting to make sure that people can come together to learn. If you go, I'm actually going to skip 2 ahead because of time. Those one more, there you go, the regional in-person info fairs. So that's what this will look like. This is who we're expecting to engage with us in these situations and in these events to really say, let's make sure you're comfortable. We can help navigate. In some cases, the state has a relationship with these organizations and they're still fostering that relationship regionally. And so we're looking forward to that. That'll be end of summer, early fall.
Hey, Steph, this is really great work and really great information, and I'm sorry to be cutting it short, but I actually wonder if we want to set time either in an educational webinar or in a future meeting to have you come back to these slides and whatever update. I feel like the last time you came before the board, we also had a lot of excitement and questions about this great new benefits, and so it might be worth us dedicate, or I think it is worth it for us to dedicate the time that this really is owed, and I think we have a lot of questions. I know I held back on a few. And you didn't even get through all your slides. So maybe final thoughts for us today. And then if you'd be so kind, we'd love to welcome you back to one of those venues to hear more.
Sure, would be happy to.
Thank you so much. And sorry, board members, hold your thoughts, write down your questions. Let's connect with Steph again about this great program. Thank you. Okay, so we will move to agenda item number 7, Oregon Health Plan Bridge and Redeterminations. Sean McNulty, OHP member communications coordinator, and Laurel Swerdlow, OHA senior policy analyst, here today to share updates on Oregon Health Plan's bridge plan and public health emergency unwinding updates. Thank you for your patience and for your work on these projects and joining us today. Sean, Laurel,
yes,
when you're ready.
Sounds good. We've got some slides that I'm sure will be coming up here in a second. My name is Laurel Swerdlow. I use she and her pronouns. I am the project lead for OHP Bridge. I'm joined here with Sean, and Sean will introduce themselves when they present next. We wanted to provide updates both on the exciting launch of OHP Bridge, and then also offer some updates on the status of redeterminations. So if you could go to the next slide here, we're going to talk through again the launch statistics that came out of that launch, offer an update on some communications that we've been doing with respect to OHP Bridge, check in on the OHP Bridge Advisory Committee, and then pivot again to a redeterminations update. So let's go to the next slide here. Our big news is that both OHP Bridge programs successfully launched on July 1st. As a reminder, OHP Bridge consists of 2 programs, OHP Bridge Basic Health Program and OHP Bridge Basic Medicaid for American Indian Alaska Native folks. Both of those programs successfully launched on July 1st. We had a transition of about 23,000 people transitioned from the temporary Medicaid expansion to OHP Bridge. There were folks who remained on the temporary Medicaid expansion. These are folks who still have outstanding pending requests for additional information, and that will then determine where they go next. There were about 1,300 folks who So those 1,600 folks remained in the TME, 1,300 folks pivoted to another Medicaid category. So for example, traditional Medicaid. And then there were just 3 folks who were closed for valid reasons. These were things like folks actually canceling their coverage themselves because they gained other coverage, or being no longer part of the household. So these are kind of the high level statistics coming out of that launch. If we can go to the next slide. So, this systems launch was actually one of the most challenging systems builds that our teams have taken on since go live of MMIS and One System. It was both complex in scope, but it also had an incredibly aggressive timeline. In spite of all that, we were really excited to have been able to launch on the timeline that we have outlined with really minimal glitches. There were two challenges that we faced last week following the go live that we just wanted to be sharing back with you. The first was following the transition to OHP Bridge. There were some OHP Bridge enrollees who were inadvertently disenrolled from their CCO. We were able to catch that right away, and all members have been reinstated with an effective July 1st date. And then there were just a couple reported incidences related to the pharmacy benefit. The first was due to a hierarchy issue of the benefits. The second was related to the system build of the OHP Bridge Basic Medicaid pharmacy benefit. Both of those issues have been resolved. We're continuing to work through various bugs or issues that pop up with that system build because there was such an aggressive timeline. We're still doing some testing right now and working through those glitches as they come up. But so far, this is sort of the status that the 2 big challenges that we faced, we've been able to resolve. Next slide. Wanting to offer just an update on the communications that we've been doing with media, with members, and with our partners. We held a press conference to announce the launch last Monday, which included speakers. We had Dr. Hothy was there. We additionally had folks from CMS, from the legislature, and a partner from Virginia Garcia joined. And there have been several articles that you may have seen that came out of that coverage, which was really excited to see. Those eligibility notices, really the main thing that happened during when those systems went live is eligibility notices went out to all members, notifying them of the transition of this coverage. And those notices, again, have been going out to members, and we have our systems teams, our call centers prepared to be supporting members as questions arise from those notices. And then lastly, we have a monthly community partner office hours, which is a space for community partners of all kinds to come and ask questions about redeterminations and OHP Bridge. And of course, we have ongoing touch points with CCOs. We are currently meeting with CCOs weekly, actually. Every Friday, we have a huddle with CCOs. It oscillates every other week. It's more of just kind of an office hours style. And on the other weeks, we have kind of formal presentations, just checking in with CCOs on implementation. And those will remain over the coming weeks as we all kind of get used to this new implementation and to make sure that there's that smooth transition. So the next slide. We wanted just to be sharing back with you some direction that we got from the task force was a request for there to be an advisory committee for OHP Bridge that's similar to the Medicaid Advisory Committee and the Health Insurance Marketplace Advisory Committee. We had originally thought that perhaps this might be a committee of the board, but we acknowledge that the board is really at capacity right now when it comes to committees. And so we have sort of started by having this, we've put forward a proposal that's being reviewed by leadership for this to be kind of a standalone committee at first. This would be the OHP Bridge Advisory Committee. And the purpose would be to create a space for partners to offer recommendations for program implementation, specifically with a focus on spending of the trust fund. If you recall, OHP Bridge has a unique funding mechanism as compared to Medicaid. There is a trust fund that may grow over time, and so we may be in a position where we're wanting to get feedback from the broader community on the best ways to be spending from that trust fund. So that's a real focus of this advisory committee, but also just creating a space for us to be reporting out on federal negotiations and any possible revisions to the bridge benefit package. We're hoping to start recruitment for this committee at the end of July. We have currently 13 members in the proposed structure of this committee, including OHP Bridge members, healthcare providers, and healthcare organizations, for example, CCOs, assisters, health equity professionals, and then representatives from OHA and ODHS. So before just handing this over to Sean to offer an update on redeterminations, I wanted to just once again thank the literally hundreds of folks who have collectively contributed to the successful launch of this new benefit. As you know, Oregon's only the 3rd state in the country to implement a basic health program, the first in nearly 10 years, and the only one to provide coverage at absolutely no cost to members, in line with the board's focus on affordability. So, over the past 2.5 years, this program was built thanks to the work of so many teams, governor's office, legislature, CMS, OHA, of course, ODHS, DCBS, and DOJ. There are staff and teams in all of those bodies that really worked really hard on developing this program. And this work was informed by feedback from CCOs, from marketplace carriers, from providers and community partners. And of course, it began with the direction and final approval from the board, from all of you. So as I mentioned, and as you've witnessed over the past 2.5 years, this process, of course, had bumps along the way, but from a staff perspective, this has been a really successful launch, and we're really proud of this work. And so we're grateful to everyone who's contributed along the way. So I think with that, I'm going to hand it over to Sean, and then we'll take questions on both REDETS and Bridge at the end.
Sounds good. Thanks, Laurel. My name is Sean McAnulty. I'm OHP's Member Communications Coordinator and also comms co-lead for the Unwinding Project. So we're going to talk a little bit about where we are in the redeterminations process right now. If we can head to the next slide. And to the next one as well. So previously, we had 10 waves of planned renewals, which were the initial plan for the whole renewal process. And then we had to add an additional 4 waves of renewals after CMS requested 30 states look into their passive renewal processes and make sure that was meeting the way they wanted it to work. We also took the time to more information about the reasons to closure, about reasons for closure to the notices, and had that all happen in a big system update that happened in May, which first started affecting the renewals starting in June when we kicked off those 4 remaining waves of renewals. Spreading out those remaining renewals, even though it was about 1 month of total renewals for us earlier in the unwinding, across the 4 months allows for additional support to that remaining population who are more likely to be either disabled or over 65 years old due to the programs affected. We can go to the next slide. The folks in the remaining group are either part of the Oregon Supplemental Income Program Medical, which is a program that specifically provides OHP to people who are legally blind, have a disability, and or are 65 or older. The other big group is people who are affected by that, what's known as the ex parte or passive renewal review request by CMS, where they had been part of a household that had previously not responded to renewals and either had their benefits restored or had their renewal rescheduled until we could adjust that process in the system in May. There's also some other members who are a member of the household of one of the 2 above groups. So not everyone affected by them is one of those 2 programs, but that OSIPM program in particular results in the demographics we're seeing in this summer renewal group being far more disabled, far more over 65 than the broader OHP population. If we can go to the next slide. So the first of those renewals in the summer waves went to members in June. Then we'll have the second block going to members next week. They have the same timeframes to respond as other people previously on the unwinding process. So the letters we sent in June have until the end of September to respond. If they don't respond by that point, they would have 60 days of closure notice before their closure happened at the end of November. And then, like anyone in the pandemic unwinding process, if they didn't respond to us, they can still reopen their case without a new application. If they respond to us within 90 days after the fact, we can still reopen that case. So that formally results in the unwinding process being, or at least the last termination should be happening in February 2025. And then the last closure reconsideration periods would close in May 2025 now. So that's our new timeline, given the extended schedule for these members. So we've still got some members going through this at this point, but most of the previous waves have been completed at this point. So if we can go to the next slide. That May system update made a bunch of changes to the renewal process that are in aggregate going to make it a lot easier for members to renew, something we're really proud of on there. A lot of them get really complicated, but the core one was the change where previously people, when we had our system make its automated attempt to renew people, if one member of the house could renew in that automated manner, but another member couldn't, the whole family would have to get a renewal packet. And we changed that so now the members of the family that could renew on an automated basis can keep coverage even if that other member doesn't respond. So we're only going to send the requests to the individuals. And so changing to that individual basis will help other members of the family keep coverage. We've also got some changes to the process itself. For instance, we're no longer allowing terminations or reductions without the member being able to review and confirm the case information. For instance, if they're over income, they get to tell us, yes, this is still accurate before we actually take the action to terminate them. That's going to be helpful for members as well in a lot of situations. There's also a bunch of changes to the request for information at renewal to make those situations clearer. That was one thing we heard a lot of feedback about, was when these notices could potentially arrive as two separate letters. That got really confusing for clients. We reduced those situations significantly, and in the remaining situations where we're required to do it that way, we significantly clarified the notices too. And then we've got a bunch of improvements to the notices themselves, such as a single renewal notice, replacing the previous multiple forms of it, like the active renewal packet, which is very similar to the application they filled when they first signed up. All of those have been replaced by this single renewal notice we've got going forward, as well as there's been some changes to make the notices easier to read and give more details about the decisions, especially when we're closing people. On the next slide, we've got an example of one of these. Next slide, please. This graphic on the right side of it is the new page one summary field, which is an entirely new feature in the notices, which hopefully is going to make it a lot easier for members to read. We've got those color-coded actions required for each of the members of the household, and this will display mostly on page one. For large families, it'll display onto page two. But putting all this information up front before they have to dig in later into the notice to find the individual details for each household member should hopefully make it much easier to read these notices. We've been getting a lot of positive feedback about that change, and that's one of the things I'm particularly proud of here. There's also been a change in the notices to focus more on the benefit category, for instance, OHP, OHP Bridge, rather than the specific programs like Magi Adult and whatnot. That also gives us a new functionality for these color-coded boxes you see on screen to actually explain specific program changes. For instance, when somebody turns when a newborn turns age 1, they would move from the Magi Newborn to the Magi Child program. And we can now explain that as a move within the same benefit category that doesn't change their benefits experience and whatnot. So we're really happy about all these changes that have happened to the notices, though we're always a work in progress, and ways to improve them are always welcome. So those will be affecting the renewals going in summer. And that was the major reason for the delay, was so we could update these processes and make it work better for the remaining folks. So if we can go to the next slide, I think we get into data on how we're doing now. So at this point, we have completed about 91.8% of the total renewals that we're going to go through. The remainder are the ones delayed over the summer. And then out of those renewals that are complete, 8% of people are keeping benefits. About 0.8% of people have had a benefit reduction. That's usually going from full OHP down to a Medicare savings program or some other form of benefit where they kept something. And then for 16.6% of people, their benefits have ended. When we compare this to other states, next slide, please. There are two major trackers there. We have been, for our press releases to date, using KFF, which shows us in third place for the renewal rate in national comparisons, though we recently learned of a Georgetown University study that shows us in first place in both of their metrics, both for all renewals, dual and completed renewals only. So we may well be the highest renewal rate in the country, thanks to a bunch of policies we've got. Next slide, please. One of which is the OHP Bridge program we just talked about. That was on its own responsible for nearly a 2% increase in our renewal rate. We also took a bunch of steps like sequencing renewals and order to make sure we had relations. We really heavily automated renewals, more so than most other states. We also did a bunch of robust communications and outreach efforts with our network of partners. We gave more people more time to respond before closing them for non-response than any other state in the nation, and also put in those continuous eligibility rules Steph talked about that really reduce the closures between renewals, which don't affect our renewal rate directly, but do affect the workload and help keep more people covered in between those renewals, so they're staying consistently covered. So really happy to see how that's going, though there's more work to be done over the summer and through till February next year. Otherwise, that's my presentation for today, and if there's any questions, we'll welcome them.
Thank you, Sean. Thank you, Laurel. Wow, what a culmination, not even a culmination, but what a reflection of years of effort and just excellent work in maintaining Oregon's progress and keeping us forward, moving forward. And so much appreciation to the two of you for this presentation and all the people behind this work that you just discussed. I'd love to welcome board members to ask, invite you to ask any questions that you have or comments for Sean and Laurel. Go ahead, Tony.
All right, it appears to be my day of questions. I apologize. This should be really quick. Laurel, great to see you. Tremendous work. So excited about the bridge program. The OBAC, I was on the Medicaid Advisory Committee, and a question came up, just arise, that we have the Ombudsman program for Medicaid. Would the OBAC assume the role of being that liaison from community members to voice their concerns? And is that the entity that will serve as like a CAC?
So I think the short answer is not quite. We are hoping that all of the existing spaces that, like our ombuds teams, our client services teams, all of the teams that currently support members, providers, the community for OHP broadly, will be the teams that continue to do that for OHP Bridge. So the ombuds team, for example, will continue to be that support for all OHP members, including OHP Bridge. The OBAC is going to be more focused on possible evolution of the plan design itself, especially as we're thinking about, as I mentioned, spending out of the trust fund. Because there's that trust fund component, we felt it really important that there be a standalone body that focuses on OHP Bridge, that we didn't want to kind of glom that onto any of the existing advisory committees.
Great, thanks.
Yeah.
Charlie?
I'll also be super quick. Laurel and Sean, great to see you both. Just a massive kudos for coordinating this incredible work. I think this is pretty pivotal to the access aspect of the work that we all really care about. And while we know this won't solve access challenges, there's going to be new things that emerge. I think this will allow us to begin to think a bit more upstream, just making sure care is covered and people can get what they need. So largely just a kudos and recognition of the complexity of this work.
Thank you so much. And since we're about to, I think, pivot to thanking Trilby, I would be remiss if I didn't note that Trilby was our executive sponsor through this work and just provided phenomenal leadership across throughout the whole process, along with the rest of our leadership team. So I want to make sure to extend gratitude to them.
Oh, what an amazing, so many victories and so much gratitude here. So excellent job to the many teams who pulled this off. I remember when the board was first hearing about redeterminations, and there was a lot of apprehension and a lot of concern, and it's interesting being on the tail end of this now and seeing not only the bridge program as part of the solution, which was not when we first heard about it. So that is just what a lift and what an amazing program that is and will be. And then also to that that there was such a appetite for learning and adjustment along the redetermination process. And it's interesting, Sean, to see you talk about the phases. And I remember when, especially Dr. John Santo was like, we should really like phase this out and put these people later. So so it was, it's an amazing reflection on that work. So appreciate the many, many hands. And congratulations to the state of Oregon for just maintaining that coverage rate and quality of coverage. And just hats off for being 1 or 3, however you want, whichever chart you want to look at it. That is an amazing accomplishment. Trilby, go ahead.
I just want to thank the board as well, because it is no small feat for staff, clearly, to do this. And the team has been absolutely amazing. But setting this path for the state, providing the encouragement along the way, taking under your wing yet another task force and another report that you would need to approve and issue that green light to the agency, all of that makes this possible. And I think Oregon is in the place it is in a significant part because we have this kind of board that allows this kind of transparency and open conversation of what the direction should be and what the response should be in times of crisis. So just really want to thank all of you for the time you give here and for the attention you've paid to this program and to the whole redeterminations process. Everyone gets credit for this, for sure.
It was the right stretch.
Yep.
It was a stretch, but it was the right stretch. So thank you everyone for leaning into it. So with that, let's thank you, Laurel. Thank you, Sean. We'll transition to the end of our meeting, which is very bittersweet as we say good luck and goodbye to our cherished and valued colleague and friend, Trilby DeYoung. Some little bio speak. Trilby served as Deputy Director for OHA's Health Policy and Analytics Division for the past 5 years, 5.5. Started her role at OHA in January 2019 and played a really pivotal role to guide and support health policy analytics through COVID-19 pandemic. And honestly, your leadership and stability helped at OHA, at HPA, and here at the Health Policy Board. As we navigated pretty uncertain waters of the pandemic, came out stronger on the other side of it. But also, you were a constant voice for the agency and leadership for this board. That was really valuable and treasured. I'm told that your leadership style is super supportive and adaptive and makes you a favorite manager amongst staff. And a trusted source. It's certainly, I will underline this, a trusted source for Health Policy Board members. So I want to take time in today's meeting to thank Trilby for her service and leadership to all these different bodies, OHA, HPA, and OHPB. And I welcome any members to share their gratitude or thanks for Trilby. Unmute yourself, raise your hand. Bill, take it away.
Trilby, I wish I could quite find the words to not only thank you, but also recognize what you've brought both the OHA and to your work with the board. The best I can come up with is not only your knowledge of the programs, but also your wisdom and your trustworthiness and there's something about your perspective that you always add something of real substance to almost every conversation. I really particularly enjoy the long conversations we had around the retreat last fall, but also your participation in these meetings and the offline meetings. We will really miss you, and I really wish you the best in the next stage of your career in life. So thank you so much for all that you contribute, not to the board's work, but to all Oregonians.
To follow up, Shirley, just really appreciate all your guidance and support. You've been such a wonderful mentor to new board members, and obviously just hearing from all of OHA staff. It's such a gift you've given of yourself of this, and just really appreciate you giving to all of those around you and to the state, and your contributions are large and far reaching. So really appreciate what you've done.
Thank you all so much for these kind words. Brenda told me I have to open myself up to hearing them, and I'm really endeavoring to do that. It really is very meaningful. So thank you. And I hope our paths cross again. I'll certainly tune in and listen to you all. I'm eager to hear about how things go. A lot of wonderful work ahead. Thank you for all the time you volunteer here. It is a huge service to the state of Oregon.
Well, you certainly were a part of our team, Trilby, and we deeply appreciate it. And we'll miss you and wish you just fantastic adventures in your time ahead. Well, thank you so much.
Thank you.
With that, I will adjourn our meeting, and we will next gather on Tuesday, August 6th. Meeting will be on Zoom virtual meeting at our normal time of 8:30 a.m. to noon. Thank you so much to everyone.
Thanks.
Thanks, everybody. Have a good day.